You can send it to me also.
Yeah, everyone.
Dr. Anand. Yeah, everybody.
Our group, our WhatsApp group.
Just patch it to all.
Yes.
MCV all. Sabina and Deepa also too.
As a ENT surgeon login fellow.
Shirish is going to control the timing because I can see the watch behind him.
Probably that watch is also on holiday mode.
Okay, we are at 12 o'clock now.
Yeah, it's 12.
Yes, sir. So
It's
need
12.
1 minute of pause and then we will start. Srinivasan, you can discuss, you can introduce all the panel.
Yeah, somebody has to give me a prompt.
Please start, sir.
Okay. Good morning, everyone. It's an wonderful day, an auspicious day. A big part of the world is celebrating Eid today. So happy Eid to all the people who are celebrating, and good wishes to all the people who have joined us here. It's my pleasure to introduce my co-panelists, namely Dr. Anand Veluswamy from Pollachi, Coimbatore, Dr. Bini Faisal from Cochin, Dr. Varun Rai from New Delhi, Dr. Sirish Gun from Nasik, Dr. Milind Navlake from Mumbai, Dr. Imad Magdi from Alexandria, Egypt, and Dr. Aditya Murthy, a facial-maxillary surgeon from Bangalore. All of you, welcome.
Thank you.
Thank you.
We kickstart the day's program about a topic which is probably for the first time in India being spoken of on the web. It's a web meeting for the first time that we have organized. It's being organized under the auspices of Sialendoscopy Group of India. We are a group of surgeons who have got together and formed a association last year. And most of the speakers today are members of the same association. This is a field which I think has entered its teens in India. It's no longer in its infancy. We have quite a few practitioners spread across the width and breadth of India. So with this basic introduction, let me kickstart the day with by passing on the mic to Dr. Anand. Now, Dr. Anand actually requires no introduction. Dr. Anand is the director of MCV Memorial ENT Trust Hospital in Pollachi, Coimbatore. He is one of the true all-rounders. He has been a mentor for many in the country. He's known to conduct fellowship programs in otology, in rhinology, in head and neck. And he probably is one of the early people to pick up the Sialendoscope in the country. He has a lot of innovations to his credit across various fields or subspecialties of ENT. And he is a man whose brain I don't think ever stops ticking. He comes out with ideas which actually defy his age. So I welcome you, sir.
Thank you, Dr. Murthy. And with that, I think I have the pleasure of giving the first talk of this day. And thank you very much for giving me this honor. So I'll go for my presentation. Yeah. The goal of Sialendoscopy is basically to leave a physiologically intact gland. The words are important because there is no point doing Sialendoscopy in a gland that has been inflamed and has become atrophic and dysfunctional over many years of obstruction. So we need an intact physiological gland for these procedures to work. Radiology is something which my following speakers are going to speak about, but sialogram, by introducing a dye into the duct and then taking x-rays, is no more advocated as a first line. Instead of that, we go more in favor of ultrasound. I'm not going to give in-depth analysis of each, but I just want to emphasize certain points which are important for the practitioners. Ultrasound, it's a simple test, but it gives a lot of valuable information about the ductal system and also the obstructions within. The ultrasound is done in the static time and after putting a silagog in the mouth. And it has to be done with a high frequency ultrasound probe. These are pictures that show even calculi that lie outside the ductal system can be made out with ultrasound. Now, this is one picture which if you can make a screenshot, please make a screenshot and keep, because when I ask an ultrasound of a patient for obstructive sialedenitis, this is the blank diagrams I sent to the patient, to the ultrasonographer, so that they mark the pathologies by diagrams and not write sentences on reports, because we find the written reports are not very clear. They use the word proximal and distal. It can be wrong between individuals, and it's better that they mark in a diagram like this. It's more useful practically. So when you have these calculi or obstructions and radiologically opacities, not all opacities inside the salivary gland are calculi. The most important differential diagnosis is a phlebolith, which can be differentiated radiologically, and a phlebolith is to be left alone and should not be operated with endoscopy. We know that indications for Sialendoscopy are many. These are some of them. The most important point I want to make is there are still doctors who refer patients for Sialendoscopy for salivary tumors. Now, this is not a test for parenchymal disease nor a method of treatment. This is only for pathologies of the ductal system. A simple introduction about the scopes. Basically, the scope here, what you see on top, called the compact scope, and the other one is called modular scope. The scopes are manufactured by two German companies. The more common among them is the Storrs, and they make both these models. Between these two, the compact model has a more robust construction, but it's somewhat difficult to introduce and to work. But if you have this, it is very difficult to break it, at least the front part of it. Whereas a modular scope, which its different cannulas are somewhat flimsy, but it can be, with one scope, you can do many different ductal dimensions. You can introduce different guide wires or baskets or anything, because the sizes of these side ports are progressively larger. But unfortunately, the front end of these modular scopes are a little tapered. Though the company has made its level best to give a nice cross-section, this modular scope's introduction is never as smooth as the compact scope's introduction. And both these scopes are best introduced with the help of guide wires. Dilators are something which we all know, commonly used in lacrimal system. And here also, these are the baskets and drills and balloons. Remember to be friendly with your urology colleagues, because they are the people who will give you introduction on how to use these things if you want to start this practice of Sialendoscopy. And the size of Sialendoscopy instruments are usually 2 French, whereas urology, they use around 4 to 6 French. So we need a little finer, but we can use guide wires from them. These are the forceps, the stents. I'm very happy to say that with the help of Dr. Murthy and Srinivas in Bangalore, one Chandrasekhar has made these stents possible for our Indian use, and it is giving me a lot of good results at a lesser cost to our patients. Guide wire is something which is very important. The one made by Cook is 0.6, the one made by Storrs is 0.2, the Storrs one is far better. We are waiting for some other company to produce that 2 French 0.2 mm guide wire. Guide wire is the way to go for all beginners in Sialendoscopy. You use the guide wire, then do this. So it's very important that any new specialty like this has to be taught to people. And for teaching this Sialendoscopy, as I told you, the modular scope is somewhat flimsy. I believe in compact scope for teaching, and because it's robust, we have confidence in giving it to residents who are trained in this specialty. These are sialolithic dimensions which can be extracted through the Sialendoscope. Huge stones cannot be extracted through the duct because the duct is limited to a certain size. Now, most of the procedures are done under local. Here you can see a swab with 4% first kept, then a dilator used. After the dilator is used, we use a 24 size Venflon to pass inside the ductal system and irrigate. We have found a lot of use for this 24 size Venflon, not only for introducing the local, it is also very much useful for flushing out debris in post-op. And some of my patients have been able to use this 24 size Venflon for juvenile recurrent parotitis. Other general practitioners have been able to use, and patients post-op also they're able to use. This is the way the guide wire is used, the guide wire with the stent. More minutes. So this is visualizing the duct. You see, when ENT surgeons look at Sialendoscopy, they get a little disappointed. Why you have such a poor resolution image? We should use a better camera. But remember, these are all fiber optic scopes and not rod lens system like our nasal endoscopes. So this is probably a good resolution. Again, the modular scope gives a little lesser resolution than a compact scope. Unfortunately, compact scope, you need minimum 2 sizes. And for doing any type of endoscopic procedure in the theater, you should have at least 2 endoscopes, because in case one thing fails, one can always go for the other. One more important thing is irrigation. Just like sinus surgery, after making the ostium, we irrigate to remove the debris. In salivary system also, we use this Cook irrigation catheters to pass inside and flush out all the debris. This really does better than using forceps and pulling out debris. So irrigation is very important, and forcible irrigation removes all the debris. Sometimes you may have to use a balloon to dilate a stricture in front of a stone so that the stone can be extracted through the duct. Now these balloons are also again 2 French stores, and there is one Israeli company also making it, but not as good as stores. You need an insulin syringe to dilate the balloon. You can see how the balloon is getting inflated and stricture is getting dilated here. This is the balloon getting deployed to dilate a stricture, following which, using a basket, we can remove the stone. So that brings me to the end of my 10-minute presentation. Thank you very much.
Dr. Anand,
yeah.
Can you please, I'm sure there are many people who have not even seen an endoscopy being done once. Can you please tell them about the need for irrigation, how the duct would look like when somebody passes an endoscope in a normal duct, and how it would look like in an inflamed or chronically inflamed duct?
Okay, I thought I wanted to cut down my time so that others can talk on it. Basically, the ducts look different with inflammation, with fibrinous exudates in case of chronic parotitis or recurrent parotitis, or with calculi impacted. And when you use irrigation, I also use little bit of adrenaline, just like how we do in endoscopic sinus surgery. That takes down the color of the ducts from reddish to whitish. And the more power you give for this irrigation, because of the blanching effect, also the colors change. So it's better not to rely on color too much, because the color will depend on of course, inflammation and also the pressure of irrigation. And irrigation is done by a separate cannula, which is to be introduced without the salivary endoscope. It is to be introduced separately. Usually it's around 0.6 mm dia, and I use a Cook product.
Okay. Sir, if you can stop your screen sharing, I can show a few slides as you're talking about a particular.
Done. Any more doubts from? 10 minutes.
Okay. It was a nice introduction by Dr. Anand. Truly, Sialendoscopy is actually Sialendoscopy. Basically, we are actually looking into the salivary ducts, and there is a limitation to which an endoscope can actually give us access into the branching system of the salivary duct. Now, the salivary duct for a Sialendoscopist's language would be proximal if it is closer to the gland, distal if it is near the papilla. There are a few things that all of us would need to remember about diameter of the duct. It's about 3 to 4 millimeter in diameter in the parotid and 4 to 5 millimeters in the submandibular duct. Now, this is very, very important because that is the limitation to which a stone can actually float or be freely mobile in the duct. Any stone which is exceeding the diameter of the concerned duct, it would be very, very difficult for an easy abrasion-less removal using a scope and the basket. The other thing that we need to remember would be a parotid duct being more tortuous, having more branches than the submandibular duct. The parotid duct also has a very acute angulation around the anterior border of the masseter, which is called as the masseteric bend, which can be a big hurdle in people in the early phase of their Sialendoscopy career. The submandibular duct is relatively straight. It falls down from the frenulum laterally and inferiorly. But the difficult part about the submandibular duct is identification of the papilla, because it generally is too narrow, and it generally requires some sort of magnification to be able to identify it. So, would any of the panelists want to add anything for the introductory lecture? Dr. Milind? Dr. Bini?
Yeah, similar to the masseteric bend, there is also mylohyoid bend. Like that is why you tend to get the calculus more at the hilar area.
At the hilar, fine.
But that is easy to negotiate actually,
Okay.
compared to the masseter.
Okay. Dr. Sirish, hi.
Yeah, Srinivas, I believe the ductal diameter of a normal duct is less than 2 millimeters, whatever gland you take. When we find it more like 3 millimeters or 5 millimeters, it is generally dilated due to an obstruction somewhere.
Okay. Dr. Imad, yes.
Yeah, I think you covered it very well here. Just another thing that I like to tell in Sialendoscopy is that when you're entering in a parotid duct, the parotid duct is actually easier to find and to scope and difficult to navigate in because of the masseteric angle. And the submandibular gland is the opposite. It's a little bit more difficult to find the papilla, but it's easier to navigate inside.
Yes.
So this is a nice thing that people can actually know both how the process goes on.
Okay. Thank you. Thank you for all your inputs. Dr. Milind, would you like to add anything? Dr. Milind?
Can you hear me?
Yes, yes, now you can.
Yeah. So I think Dr. Anand spoke about clarity of the picture.
Correct.
Which a new person would feel that the picture is not clear. So there are two things about it. Firstly, here the medium of surgery is water. So whatever picture is underwater. Secondly, there would be a lot of suggestion that why don't you increase the light? But since the diameter of the scope is limited, the fibers are very less. So even if you increase the light, it just makes picture white. It doesn't make the picture bright.
Okay. Correct. So that's sometimes called as the full moon sign as we enter into the duct, and then the light actually reflects off the duct, and then the whole picture is only a white round structure that we see on the monitor. Yeah. Okay, so we will move on to the next lecture. I now invite Dr. Bini Faisal. Dr. Bini Faisal has been my senior in college at Bangalore Medical College. She is currently the head of the department of Amrita Institute of Medical Sciences, Cochin. She too has been involved with Sialendoscopy for nearly a decade. And now I would like her to give her lecture on Sialendoscopy in Sialedoscopy. Welcome, Dr. Bini.
Thank you, Srinivas. Hello, everybody. I'll share my screen now. Okay, so in the era of Sialendoscopy, like how we'll approach a case of Sialedonitis. So that is my discussion today. So if you consider the non-neoplastic pathology, Dr. Anand already said, we have the infective, obstructive, and the whole plethora of inflammatory conditions, of which obstructive and inflammatory can be treated quite effectively by Sialendoscopy. So of the obstructive, we have the calculus and the stenosis. Now, when we say Sialedonitis, the party involved is called as the secretory end piece, where you have the acini, you have the intercalated and the striated duct system. So there is some amount of Ductitis and Adenitis actually involved. So as we said, Sialendoscopy is a duct-centric treatment. Now some trivia. Why the parotid is commonly involved in Sialedonitis? Because it is unprotected, does not have mucin, it is predominantly serous. And in the resting stage, it's a submandibular gland which is producing 70% of saliva. And in the stimulated state, it is the parotid. So all glands are important. So we have to strive to preserve all. And as far as the history is concerned, specifically make sure to ask about mealtime syndrome, like the bulging of the salivary gland when a food is taken, Sika syndrome, any metabolic conditions, are they on any medications? All these aspects you have to ask. So if there is a history of mealtime syndrome, the classification is quite easy. So that is obstruction. If no, we have to work up on the whole inflammatory conditions. Now, calculus all over the world is treated now in two different ways. People who have access to Sialendoscopy and who do not. So those who do not, they do a sialendocotomy, and but the problem are they might be missing on a concomitant stenosis, they might be missing on other calculi. Those who have access to Sialendoscope, whether the calculus is palpable or non-palpable, we always do an endoscopy. Then if required intervention, whether it is combined or whatever. Now, if the calculus is not seen, even then we tend to go for an assisted approaches. We make use of radiology or somehow try to get the stone out. Only if it fails, ESWL, other things are not working, we should think about sialedonectomy in this era now. So for the diagnosis, for a condition of Sialedonitis, you cannot say these are the set of investigations. It depends on various conditions. So X-rays actually has not yet become ENT's friends, though our dental colleagues are using it. But ultrasound is fair enough investigation for most of our pathologies, especially calculus in the parotid area. And all the benign conditions, mostly it is confined to the superficial part. But if it is a deep part, of course, you need an imaging, CT or MR, as the case may be. Now, if you see a bright curvilinear echo with posterior acoustic shadowing, that is suggestive of calculus. But if you have a mealtime syndrome in the submandibular, ultrasound is normal, I would advise you will have to go for a CT because you might be missing out on a calculus, which is in the middle part of the duct. So CT does have its role. It will tell you the number of stones, and you can locate and you can even plan also. Now, this will be a general Sialendoscopic setting. So you plan your anesthesia, planning on exposure of the papilla, then dilate it and do the scopy. If you have done an intervention, you will have to do a check scopy. So Stenson's papilla dilatation. So as you know, it is opposite the second molar, and with the lacrimal dilators, there are about 8 sizes of them. So try to enter just not more than a centimeter, because you might be pushing something inadvertently. Then you dilate serially with a conical dilator also before you push in your scope. And once the scope is introduced, by under irrigation and flushing, you tend to proceed and keep the center of the duct in view. Sorry, I'm not able to see the cursor. Yeah. So once you see the calculus, try to keep the view of the calculus in the middle, and you deploy your basket. And the basket goes behind the calculus. This is a 4-wire tipless basket. And once it has engaged the calculus by you close the basket and then gradually withdraw it. And now parotid, as there was discussion before, the opening is only around 0.5. So it tends to get stuck at the papilla. Then you might have to do a papillotomy to take the calculus out. Now, so this is an old video. Now, if I get a chance, I will not open the papilla. I might do open the duct a little more distally so that the papilla is preserved. So if you are doing a papillotomy, you have to do a stenting. The same way is the submandibular papilla. So you do a lacrimal dilatation and then go for a conical dilatation. And the pattern of calculus removal is the same. So engage the calculus and try to remove it. You might need a sialodocotomy, which is nearer to the papilla if it is getting stuck at the papilla. So these are some associations you see. What happened?
Vinny, probably you'll need to reshare your screen.
Yeah, I'll do that.
I think so.
It closed or something. Sorry, I'll just get back to you. Yeah. Okay, so some associations which we have seen is there might be a stenosis and the calculus will be behind it. So you might need to dilate it either with a balloon or something. And this, like, you can see that I'm pushing it with a balloon and dilating it. And then I go for the calculus behind it. And calculus is caught in the usual pattern.
Vinny, we are not seeing your screen yet. I'm sorry to interrupting. We're not seeing your screen.
Sorry. You're not seeing?
No. Yeah, now we can see. Now, yeah.
Yeah, so this is a case of overstepping the calculus. Sometimes, like, you push in the scope with some force, you might bypass it and go much beyond, and then you will not see the calculus, and you might see the calculus while you're coming back, and then you retrieve it. So always make sure you keep the lumen in the midline while you are coming back also, otherwise you might miss out. So if we are talking about the inflammatory salivary disorders, as I was talking, there is a whole lot of them. If you look at my numbers like stenosis, JRP, Sialedinitis, I have equal number almost of Sialedinitis and juvenile recurrent parotitis. So it is a non-infective, non-suppurative inflammation with a biphasic age distribution, children less than 6 years and more than 9 years, and it is multifactorial. And sometimes we do see children with multiple investigations, but usually only ultrasound is required. And it shows some hypoechoic areas with silectasis. You will see some intraparotid lymph nodes. And this is a beautiful article, 2018. It is a meta-analysis which shows they say like everybody better stick on to a criteria for diagnosis of JRP, like the age be less than 16 years, or at least consider 2 episodes in the last 6 months. And either it should be a recurrent monolateral or a bilateral swelling. And they have suggested some exclusion criteria also. The contention is, though the Sialendoscopists all over the world are literally saying it is the treatment for juvenile recurrent parotitis, this meta-analysis says they cannot say for sure this is the treatment because there has been no randomized controlled studies. And they say like it is not, they're not very sure whether it is the natural burnout of the disease. But as individual surgeons, we know we do get results for smaller children and who did not respond at all to the conservative treatment. So randomized studies are a must. So when do you do Sialendoscopy? When you have at least 2 episodes in the last 6 months. So this is the video of Sialendoscopy. The pictures on either side. One is a normal pink duct, and the other side you can see the white cadaveric kind of mucosa. Now, what helps in JRP? Is it the mechanical distension, or is it the water hydrostatic dilatation? Is it the steroid? So separate studies have been done on all these, but nobody has been able to pinpoint. So that is a hilar area. You can see it is white. If you get a chance to do a subsequent wash, we can see that the duct becomes more pinker, more pink. This is an in-house study, JRP on 22 cases. And you can see in the first is a visual analog score, almost 0 for 12 patients compared to the conservative group, where the visual score is in 15 patients, the score was quite high. And this is the number of attacks. It is almost 0 to 2 for almost 19 patients. So not all parotitis is JRP in children. Think of a primary pediatric Sjogren because 80% present as glandular involvement. And we should know that only 38 to 60% is positive. So if we have doubts, now this is where I said there is no tailor-made investigation. So here we have to do a rheumatology workup, ophthalmology, Schirmer's test, lip biopsies, and things like that. Now this is another scenario where I had a child when I did in 2013, 3 failed Sialendoscopies, did a parotidectomy, and there was a tiny focal non-caseating granuloma. They did not take up my advice to go to rheumatology. Came at 12 years with similar one on the right side. See the MRI, multiple abscesses, and the endoscopy showed a really dirty duct with the multiple inflammation and discharge. Of course, the Sialendoscopy did not help him. And when we did the further evaluation, elevated AC, and it was a juvenile sarcoid. So once the right treatment was started, we could save that gland. He's in remission. In between, I did a wash for him once. He had thick secretions and he had pain. Now, this is one common condition. People come worried about it. We just have to console them. They do not need Sialendoscopy. And I had one case of pneumoperititis, which was dilated duct with some bubbly saliva coming out. But this guy, I just had to put in a needle. Like you can see the CT also, and it just became flat. So the evaluation, whether you have to do IgG, IgM, connective tissue, all these depends on the case scenario. So when you're doing a lip biopsy, at least make sure you give the pathologist 4 to 5 glands, and they tell it a focus score more than 1 if you have some 50 lymphocytes in one field. So I did a study on some 60 cases of Sialedinitis. You can see that more than 1, we had 10 patients, of which 5 went on to get proved as Sjogren's. And in this 15 cases of less than 1, these patients also did not do well with Sialendoscopy. They tend to have some complaints. Some findings you tend to see in chronic parotitis, I would like to share with you. See, this is one pattern you see. We call it as a 1 in 2 pattern. At bifurcation, one duct gets stenosed. And another one you will be seeing will be, this is a 1 in 2 pattern I was talking about. Sometimes you see an acute bend, the rest of the things will be normal, and you will need a guide wire to go beyond it. And here you can see as I was trying to negotiate, all the secretions are coming out, and then I was able to go. Another pattern you see will be strictures, which you have to dilate. I'll not be going into it because that is Sriharsha's field. And Later, you will see a dilatation, then again stenosis. Classical picture, as you see in a xylography, you can see. There was cases where there was total stenosis, could not see the duct at all. Then I had to open it up and then do the scopy. And the similar way, there was total stenosis of the submandibular also, could not see the opening, and I had to do a distal silar dichotomy and then introduce the scope. Strictures and radioiodine parotitis, I'll not be doing with that. This is another interesting case, the same pattern of dilatation and strictures. So what I did was I created a neo-ostium somewhere near the second premolar, and this is a subsequent scopy through that, and that was normal. She is quite okay now, I think 6 to 7 months. So of the 60 cases of these patterns of sialedenitis, almost half of them fully responded. Partial responded are off and on paracetamols, and the not responded group are with rheumatology. And none of them required a sialedinectomy. So these are the cases in the recent past before I've done sialedinectomies for them. So if your patient is not responding, think of immunological factors, and they might be able to help you also. Thank you. Sorry for some confusion in between. I think
that's okay, Bini.
Yeah.
It was a very nice lecture. Thank you.
Thank
Now
you.
I would request all the other panelists to unmute. And if any one of you have a question to ask, you can ask. Dr. Imad?
Well, actually, that was a very nice presentation, Benny.
Thank you.
Interesting to ask you about the case of pneumoporotitis. You said that you aspirated the air and it went away. Did it recur again, or was it?
That boy works in a temple, and he wants to have that, I don't know what you call that, the trumpet kind of thing. So he used to swish air inside the mouth, and that was causing it. So we gave him some psychological consultation, and I did call him once, and they said he's okay.
Dr. Bini. Funny
Hi,
that
Aditya.
So, hi. Funny that you said so. I have my colleague Prithvi sitting next to me, and the moment you said psychological consultations, our jaws dropped, because we came across something very similar. A youngster who would manage to push air into his parotid duct, and he would end up having a kind of a false pneumoperititis. And the moment he opened his mouth, because he couldn't keep the seal in, it would flatten out. And he needed psychological counseling as well. So perhaps the valve of the parotid ductal opening, the papilla, isn't as absolute as we would like it to be. And perhaps this pneumoperititis may not be as rare as we think it is. And we perhaps should, this is a case in point where journals don't accept case reports, and such weird and wonderful cases slip under the radar. And we are all left thinking that we are the only ones who've seen this. It is very fascinating.
Yes.
I have a few questions from people who are watching us on Facebook. Sirish, I will get back to you for your comment. Sure. There is a question from Dr. Prakash Munka. Any one of you can lift your hand to answer this question. The Stenson's duct is difficult to find. Tips and to avoid false passages. I think you need to probably correct him. It's the Wharton's papilla which is more difficult to find. Dr. Imad?
Yeah, that's actually correct. It's all the opposite way. The Stenson's duct is much more easier to find. The reason of that is that it's present in the cheek, and it's in a more tougher tissue. As opposed to the Wharton's duct, you're actually trying to manipulate in the floor of the mouth. So that's much more fragile tissue. And the first trick when you're trying to getting the Wharton's duct is that don't touch anything with tooth forceps or mosquitoes or anything. We do what we call the non-touch technique of papillary identification. You just get like a cotton swab or something which is very gentle, and you try to find the papilla under vision. I like to personally use the microscope. Some people do it with the loop. So magnification is another very important point. Third point is that before performing the surgery, always reserve your saliva inside the gland, because that can be your friend. So when you're trying to find the papilla, you can actually squeeze on the gland, either the parotid or the submandibular gland, and that gives you a gush from the opening of the duct, and that can actually let you see where the actual position of the saliva is coming from. So that's another trick. If you can't find it, some people advocate to put on a drop of methylene blue that can actually, I don't like that personally, but some people advocate that. It can actually give you like a contrast. You can see where the flow is coming from. Lastly, and God forbid if you don't find that, like Dr. Benny showed, you can do a cut down either on the in the floor of the mouth on the Wharton's duct or in the Stenson's duct area. But I think these are the most commonly used tricks. One more last thing, the Wharton's papilla is more difficult, as I said before, to find, and the duct of the submandibular gland is easier to navigate because it is actually more straight. Where opposed to the Stenson's duct, it is much more easier to find because you have it in a tougher tissue and the papilla is evident, whereas the navigation inside the Stenson's duct is much more difficult because you have to actually bypass this mesenteric angle.
Okay, thank you, Dr. Imad. Dr. Sirish?
I mean, I agree with whatever Imad and the previous two speakers have said about the papilla. I believe one important point is use magnification. Use a loop or microscope, whatever you are comfortable with. But use a magnification. Your chances of finding the papilla increase manifold. Yeah. So that is one thing which I have been following right from the beginning.
Okay, thank you, Sirish. Dr. Milind?
Yeah, one more tip in finding. If you are doing only one side, always compare to the other side papilla. If you look on the other side, it is usually on at the same side, so it would help you and obviously increase your magnification of the microscope.
I think all the panelists. Yes, Binny.
Yeah. Probably one more idea is to increase the saliva so that you can, when you massage, you can see it. So advise the patient to take vitamin C. And if it is under general anesthesia, you can instruct the anesthetist not to give glyco or atropine.
Correct. So, I think all our procedures, glyco and atropine are generally avoided. And many of us actually use lime water or lemon juice on the tongue tip, even in the OT to stimulate. I think most of the panelists have been able to tell us exactly what needs to be done with respect to this. I think we as ENT surgeons and many facial-maxillary surgeons, we see the oral cavity every day. So if we just make the attempt to see the papilla on either side of the buccal cavity as well as in the floor of the mouth, for every patient we examine, we get an idea of how the papilla looks like. And then that actually adds to our operative experience too, without even actually handling the papilla. Yes, Dr. Anand.
I think one more technique is the assistant massaging the gland from beneath. Correct. And that way we can see the saliva coming out. During that time, put a dry swab and dry out that papilla area so that you can see the drop of saliva coming out. And between the magnifications, I've used both the loop and the microscope. And now I prefer the microscope because I feel it is more larger, the image.
Correct. No, I think most ENT surgeons would love to use the microscope. We are familiar with it. Aditya is jumping on his seat to probably join us. Aditya, I have another question for you. I will combine two questions. What is the size of the calculus that can be removed? I think I actually answered in while I was speaking previously. If calculus is at the hilum, can we still try Sialendoscopy and remove it?
Which gland? First question.
No, answer it generally because Varun is going to talk about it. Dr. Milind is going to talk about it.
Well, yeah. Yes and no. Yes, it can be removed if it is of the appropriate size, and you can get a basket behind it. And it's not just the size that matters. It is the shape and the outer texture. If it's a rough calculus, even of an amenable size, you may find that it may get stuck in smaller strictures, whereas a smoother, a bullet-shaped calculus can be drawn out gently and carefully. And for ones which can't be, there are ways of removing it with a Domia basket. Varun will talk about it. It basically has to be broken down into manageable sizes. And the third point is a combined approach, which both I and Dr. Imad will talk in a while, and we'll reserve the question for them.
Okay. So now, Dr. Varun, I have a question for you.
Yes, sir.
If you would like to So, are you able to see my presentation?
Yes, sir.
It doesn't open the slide which I want to open. Okay, of these three baskets, which would you use, and have you used all of them? If so, when and why?
So I have not personally used the middle one. I've used the upper one and the lower, the tipless one.
Mm-hmm.
So it needs to be understood that every case is different, and every stone's morphology as well, where it lies within the duct, has a decision to play on which basket you would use. The advantage of the bottom one is that you can load it from the front. You need not always go behind the stone to load it. Whereas with the first one, you have to either go alongside or beyond the stone in order to remove it. So in hilar stones, I would prefer the last one.
Last one, correct.
Yeah. And for the mid-ductal, yes, of course, the first one is perfect.
Okay. Thank you, Dr. Varun.
Thank you.
So we move on to our next lecture. We have now listened to Dr. Bini speaking quite in detail about calcular sialedenitis as well as non-calcular sialedenitis and what her experience has been. Now there are other reasons why there can be obstructive sialedenitis, and the second most commonest reason would be we encountering strictures and narrowing of the duct. So Dr. Sirish has a wide experience. Dr. Sirish Ghan is a consultant ENT surgeon from Nasik, which is in Maharashtra. He is a very popular faculty all over India. I think he has given innumerable number of lectures, demonstrations across India as well as across the world in the field of Sialendoscopy. I now request him to deliver his lecture.
Okay, thank you, Srinivas, for this wonderful opportunity, and a great hi to everybody, the speakers and the participants, and happy to all of you. Let me share my screen first. Okay, so I'll be talking about managing strictures of the salivary gland ducts, which I call the new frontier. Why I call it the new frontier is because before Sialendoscopy came into the picture, we really had no avenue available to treat these strictures. In the picture on the right is the building of my alma mater, BJ Medical College, Pune, and I'm greatly indebted to my college for, getting me where I am today. What exactly is a stricture? It is actually an abnormal narrowing of a body passage, and it refers both to the process of narrowing and the narrowed part itself. And as we can see from this illustration, when a duct gets narrowed, it obstructs the flow of saliva. So why are strictures so important? So if you look in my experience, I have found that nearly 80% of the salivary gland disorders that come to me are obstructive. They have some kind of obstruction in the salivary ductal system. Only 20% have parenchymal pathology. So I think Dr. Anand touched on this point, that we will be dealing with Sialendoscopy only with ductal pathologies. And I was asked this question once in a meeting that, oh, so you can't do anything to the parenchyma. And I said, yeah, we can't do anything to the parenchyma. And then somebody senior enough, he said, oh, I think that's an useless technique. So I replied back that is it as useless as a bronchoscopy in a parenchymatous lesion of the lung. So let us put that Sialendoscopy treats nearly all obstructive disorders, nearly all. If you look at the prevalence, this study was done at GTBH hospital by Dr. P.P. Singh, who was the first one to introduce Sialendoscopy to India. It shows a prevalence of 1 new case per 10,000 population per year. And we have found, I think it should be the experience of nearly all of us, that strictures are nearly as common, because Binny's series also showed us nearly the same numbers for stones and strictures. In India, today, it would translate to around 1.3 lakh cases of strictures annually. So there's a huge caseload. We need to be aware about it. Once we are aware about things, then we'll start diagnosing and then we'll start treating them. So what are the different etiologies? As you can see, ductal narrowing can be seen in juvenile recurrent parotitis, in something called as adult recurrent parotitis, sialadenitis, sialadenosis, Sjogren's, radiation-induced sialadenitis, radioiodine-induced sialadenitis. And this is an important thing. There have been studies which show that between 25 to 59% of patients taking radioiodine for thyroid cancers, they develop parotid submandibular strictures. We can also have sialoceles, which develop proximal to a stricture, and sometimes it can be acquired because of trauma. So how do I treat these patients? Now, this patient is a symptomatic patient. That's the reason why this patient is in my OPD. So if I have a symptomatic patient who is complaining of salivary gland swelling associated with fever, associated either with meals or without meals, what I do is I get an ultrasound done. The ultrasound tells me if there is a stone, it tells me a stone. If there is no stone, there are 2 or 3 possibilities. The most commonest is there is a stricture. So what do I do? At this, if I have a stone, I will do a Sialendoscopy. If I have a stricture, I will do a Sialendoscopy. But sometimes I fail to find anything in a Sialendoscopy. That's rare, around less than 2% of my Sialendoscopies. If I find that there is a discrepancy between the ultrasound and the Sialendoscopy, then I will do an MR Sialography for further evaluation. Though sometimes now with experience, I will directly go on to do a MR Sialography before I do a Sialendoscopy in cases which I anticipate problems. Now, as I said, the investigations for stricture, this picture on the left-hand top corner is a classical Sialogram. We have stopped asking for Sialograms because finding a papilla is not all that easy, as we all realize when we start doing Sialendoscopy. So I don't want a radiologist to try and then traumatize the papilla, and then my chance of doing a Sialendoscopy gets lost. The other thing is ultrasound gives us a good report. If we want further details, we will always do a MR Sialography. As you can see in this duct, you can see strictures, areas which are not filled up. The advantage being we don't need any contrast. MRI does not have radiation. The saliva itself acts as contrast. And we can have excellent pictures. Now, if you can see, this is the proximal papillary end. You can see an entire dilated duct, and then you can see the distal ducts, the proximal ducts inside the gland. So we can get good image reconstruction. We can have 3D pictures if we need. And that gives us a better idea of what we'll be encountering when we'll do the Sialendoscopy. Now, papilla dilatation, everybody will have a different set of instruments. This is papillary dilatation. You can see it's the parotid papilla on the right side. I'm using a conical dilator. And the most important thing is be gentle about dilating the papilla. Do not insert it too much, because if you injure your duct near the papilla, then your chance of scopy is reduced. And if your scopy is reduced, you generally, people will end up with excision of the gland. So in strictures, what happens is, as you can see, the picture on the top shows a huge swelling in the parotid region, and the one at the bottom is 6 hours post-op. Now, just take a look at this video. As I went into the parotid duct, I found a sudden narrowing, a stricture there. Can you see the sudden narrowing? And then I passed a guide wire, which is 0.6 millimeter in diameter. I used the modular scope, and I find it one of the best instruments to dilate a stricture because it can provide ample force to dilate a stricture. Just a word of caution, do not dilate too much because there are certain complications of trying to force your way in through. As you can see, I followed the guide wire and I have entered into a cavity which has a lot of flotasm. Now, this part of the video is about evacuating that cavity. And at the end, you can see if the guide wire is 0.6 millimeter, the cavity is nearly 3 centimeters. So it was this big a sialocele beyond the stricture. At the end of this procedure, we obviously put in a stent, but such strictures will require recurrent dilatation, say about 2 or 3. But this is again a non-invasive, nearly non-invasive treatment for the dilatation. So why do stricture dilatation? How does it help? As we all know, Poiseuille's law states that the flow is directly proportional to the 4th power of the radius. If you look at this graph here, you will see as the relative radius increases, the flow increases very rapidly. Just to give you an idea is if the pre-op diameter of the duct was 1 millimeter and I was able to increase it to 1.5 millimeters, the flow does not increase 1.5 times. It increases 0.5 raised to the times 4, which comes to around 5.06 times. If from 1 millimeter I increase to 2, the flow increases to 16 millimeters. And from 1 millimeter, if I increase the diameter to 2.5, it will increase to 39 times normal, considering that all other factors remain the same. That is the pressure difference between the two ends, the viscosity, and the length of the duct. Now, again, this is a case, as you can see, right parotid sialocele. This was seen beyond or proximal to the stricture. This is an intra-op picture where you can see the endoscope has gone in and you can see the sialocele being illuminated. And this is the post-op picture. I think the smile says it all. Let's have a look at the video. So here again, we see a whitish duct, narrowing of the lumen. So the technique that I follow is the same. I rarely use balloons, but balloons are also good for diaphragmatic strictures. So there goes the guide wire, and I follow the guide wire in. The bevel of that modular scope helps in, dilating. And as you can see now, I'm progressively entering into a larger cavity. As you can see, the size of the guide wire to the size of the cavity, you can judge through that. And once I have dilated that stricture and gone into it, I can see the proximal dilatation. You can see 2 tributaries coming there. And as I withdraw, you will see the change in the diameter that has happened because of this dilatation. And as I've explained, on the basis of Poiseuille's law, the diameter has increased quite significantly. So the resistance to the flow of fluid will be very much reduced, and that helps a lot. Now, at the end of this procedure, I use a stent. This stent, initially we have used various materials, but what Srinivas and Aditya have designed, I've been using that. You can see this stent. It is available in whatever diameter you want and whatever length you want. It has a cuff at its distal end through which you can suture it to the buccal mucosa. And you can see the guide wire was placed at the end of the scopy, and you see the stent being passed in over the guide wire. And once the stent has been fully passed in, you can withdraw the guide wire and you can suture the stent to the buccal mucosa. At the end of the procedure, I give a hydrocortisone, diluted hydrocortisone wash. This is also one of the previous stents. This is an old video, but you can see once we have dilated the sialocele, dilated the stricture and gone into the sialocele, you can see the amount of fluid that can come out. It's like a tap on full flow. But that is because of external pressures. I mean, that is the cavity which can be filled with the irrigation that we do when we are doing Sialendoscopy. Now, what post-op care do we require? I give ice fermentation locally. I ask them to avoid sour foods because we have traumatized whatever. When we are dilating a stricture, we traumatize the mucosa. There are no two ways about it. So I don't want more saliva to flow till the time that the duct epithelizes. Antibiotics, corticosteroids, and stent generally to be removed at 3 weeks, but sometimes because the buccal or the oral mucosa is not as strong as the skin, the stent sometimes comes out earlier. If it comes out earlier, I don't reintroduce it. But if I can keep it for 3 days, 3 weeks, I keep it for 3 weeks. Now, I think a similar case was shared by, I think, Binny. This is a case where you'll see this is the right submandibular papilla. Here you can see something called as the left submandibular papilla. This was after tongue tie release done 1 year ago. So I went in, I couldn't find the duct properly. I dissected, I found out the duct and then did a docotomy, passed a scope through this, confirmed that I was inside the duct, and then passed a catheter over my guide wire and created a neopapilla. This was the end result. Now, this is a large papilla because we know that any papilla that we create, any opening that we create in the floor of mouth tends to shrink quite a lot. But this meant that I did not have to excise this submandibular gland because that was the only option given to him by a few others whom he had gone to. So we are still, this is a functioning gland, this is a physiologically active gland, and we have been able to preserve this gland. Now, the LSD classification of strictures says S1, which is a diaphragmatic stricture. The balloon works best here, I believe. S2 is a segmental stricture in the main duct. S3 is the entire main duct strictured, and S4 can be the entire ductal tree strictured. This picture is generally seen in Sjogren's. Even if we are not able to dilate this, what happens is the irrigation, the steroid, whatever, they do tend to give patients good symptomatic relief. And whenever I am counseling these patients pre-op, I tell them that I am treating the effect of the disease that you have and not the cause of the disease. So as long as we don't treat the cause of the disease, you may get a recurrence. Most of the time, say around 70 to 80% of the patients do not require a second dilatation. And those who require a second dilatation are very willing to undergo that dilatation because for 3 to 4 years, they have been relatively asymptomatic or their symptoms have been easily managed, not as strong as before. This is old data, but if you look at strictures, you will see, if you look at the submandibular gland, strictures which are in blue color are only 19 as compared to 106 stones. And in the parotid, you will see stones are 37 while the huge number of strictures are present. So again, this is a tabulation which shows you can see strictures more common in the parotid as compared to the submandibular. Complications can happen. We have to be very careful, and I would re-emphasize this point that don't buy a scope and start doing Sialendoscopy. Get yourself trained because that is the most important thing. This is not something that we are used to. So let us get used to it so that we increase our yield. As you can see, if I pushed in too hard, I have degloved this cuff of mucosa, that is the tube, and my guide wire is outside. Fortunately, what I did is I withdrew this guide wire, managed to put it into the lumen. Obviously, this was quite deep inside the tissue. I couldn't have pulled it out and sutured, but this patient became asymptomatic over a period of time. So degloving can happen. Be really watchful about it. This patient again had a parotid this thing, and you can see she was very happy. She was very happy with it. She came back 6 years later and said, okay, I now am getting symptoms. Can I get that scopy done again? So if you look at Sialendoscopy in strictures, I would say it is nearly non-invasive. It is an organ preserving. It is a function preserving modality for diagnosis and treatment of nearly all obstructive salivary gland disorders, it is cosmetic and has very low morbidity. So if from a stage like this, where the diameter of the duct is nearly the same as the guide wire, we can end in a post-op state where the diameter is quite enlarged, we are going to give a patient good relief. My gratitudes to Professor Francis Marshall. I believe all of us have been his students. We have learned Sialendoscopy from him. My parents, my children, my wife, without them, this journey would not have been possible. I would say thank you, and I would leave the audience with this to ponder upon.
Thank you, Dr. Sirish. That was wonderful. I think the emphasis on save the gland has been quite forceful. I think all the panelists would agree that if you are picking up Sialendoscope, your last option, or rather the option of removing the gland, would never be there. We would try our best not to remove the gland for an obstructive lesion. A couple of questions from the audience. Dr. Sirish, now, do you use general anesthesia or local anesthesia for all your cases? One, in stricture, would you differ?
Right. I started doing, local anesthesia for both the parotid and the submandibular. Later on, I shifted to GA. Now, most of my cases are under GA, but for a stricture, I would do it under general anesthesia because the amount of force required to dilate a stricture is quite high. And that can be really discomforting. I mean, stricture dilatation anywhere in the body is painful. So local anesthesia, I'm not very comfortable with. Generally, if we can give a good general anesthesia, which is, not a question now about this thing. So I do all my strictures under general anesthesia.
Okay. Any particular reason why you switched over from local anesthesia to general anesthesia?
I found that, sometimes the patient keeps on moving, and this, the scopy itself is in a kind of a mobile structure. So we have difficulty in keeping our view like end on, seeing the lumen. As it is, there will be some handshake, there will be some movement happening. If the patient is under local anesthesia, that also adds to this thing. Some amount of discomfort to the patient. So that's the reason why I've shifted from local to general anesthesia.
Okay. Question to Dr. Bini for your previous talk. It's about treatment protocol for juvenile recurrent parotitis.
Okay. So suppose the child is coming to me with the recurrent parotitis and it is monolateral, one-sided, and I will see how many attacks the child is getting. If it is, say, fixed to a criteria of, say, 2 attacks per 6 months, in 6 months, I will give them the offer of Sialendoscopy. Okay. But now for all juvenile recurrent parotitis, I will routinely go for the lip biopsy. Unless some references come specifically asking for parotid biopsy, because some in periphery, they have started doing all these IgG and all those subclasses. And if recently one referral came specifically for a parotid biopsy. Otherwise, I generally go only for a lip biopsy. Okay. And then I'll do for the connective tissue screening for juvenile recurrent parotitis. That is routine for all my cases.
Okay. Now, how significantly does Sialendoscopy alter a child who is suffering from recurrent parotitis?
Very significant. Generally, initially when I started, I used to give 3 washes in a gap of 2 weeks, and that was long back. But then I realized that it is not really required. A single wash is required. And now I see that patients who come back with complaints, either their focus score will be less than 1, not 0, or not even more than 1. That is not fitting into Sjogren's either. So they have some immunological disorder. Such patients may need a subsequent wash.
Okay, thank you, Bini. Sir, Dr. Aditya had lifted his hand first, and then I'll come over to Dr. Anand. Dr. Aditya, you have to unmute. You have to unmute.
Can you hear me?
Yes.
Yeah. My apologies. This is very interesting. Have you had any linear follow-up of your patients? Because we here have always maintained that Sjogren's in a majority of patients will become seropositive, GRP in a majority of cases will become seropositive Sjogren's. However, we do not have, we have been doing this stuff only for about 8 years. We do not have any long-term reviews of any patients who have turned into their adulthood and turned up with Sjogren's, because they do not have anti-SSA, anti-SSP in their ANA profile. Do you have anything to the contrary that makes you think so? Because we all agree with you.
Yes.
Is there any evidence?
Till now, like I think my initial cases was in somewhere around 2012, and after that 2013 I started doing consistently. But even in this long follow-up, I have not found a conversion like where I can prove it as Sjogren. But when the focus code became positive, we started working on that, and as I showed, like 5 cases turned out to be Sjogren. But the initial negative case becoming positive, I've not had. So probably like I should start calling the older patients. But it is quite classic when the lip biopsy comes as there is periductal lymphocytoplasmic infiltrates, focus score less than 1. We know they are going to come back with issues. So it is some immunological disorder.
Okay. Dr. Anand? Sir, you have to unmute. You have to unmute.
Done. Question to Dr. Bini. We are all doing the blood tests, SSBs or anti-Rho, anti-La, and we find that in many cases they come negative. One of the reasons they are coming negative is because Sjogren is any MD doctor treats with steroids, and if they are given a steroid medicine for 1 day, for the next 1 month, all these tests will be negative. So one has to make sure that the patient is not on recent steroids before you order blood tests. Lip biopsy is something which is a little invasive, and I think we'll be comfortable doing it only after doing the blood test. How about you, Dr. Bini?
Yes, I do it during the Sialendoscopy, sir, because most of these cases are children. Adult, I always do under local anesthesia, the lip biopsy. For children, along with the Sialendoscopy, I do the biopsy.
Okay. No, I will have to butt in because for want of time, we have already completed the 70 minutes. There are 2 more questions from the audience. Is there a upper limit for the irrigation fluid that you use? How much of fluid would you use? Anybody can answer. Bini is on screen, so you can answer that.
Actually, Varun had raised his hand. Would you
okay,
want to?
I'm unable to see Varun on the screen. Varun, I think since you will be talking about laser, where we need a lot of irrigation, let him answer the question during his talk.
Yes, I will be addressing that during my talk.
Yeah. So I think that thing is done. Now, for a case like Sjogren's, as is the most of us do think a little bit laterally in our practices. There are people who have raised a question about can we just dilate the papilla and then irrigate steroid directly without a Sialendoscope? So, if it is yes, what should they be careful about? If no, why? Dr. Anand, you have to unmute.
Sjogren's will have multiple strictures, and by just passing in irrigating fluid, we don't know whether the pointing strictures are going to be dilated. It's worth doing one Sialendoscopy and then followed by subsequent. And I have one more technique for the Sjogren's. I usually find out the level of stricture by measuring it in centimeters. And after the that can be done in 2 ways. During the Sialendoscope, the modular scope has the compact scope has the centimeter marks, so that way we can measure. Second, your stent also has centimeter marks. Either way, the major stricture has to be measured so that once the stent is in place, post-op, not during, post-op after a week or 2, we can inject a little bit of depo-steroid there, and that gives a far better success rate in these strictures.
Okay, thank you, sir. Now, there's a disclaimer here. All of you are assuming that I have been contributory in the development of the stent. No, I am part of the group with Aditya and Prithvi Bachalli. The stent is actually called Murthy Bachalli stent. The credit goes to Prithvi Bachalli and Aditya Murthy solely. So all of you are using
there is
their
a
stents.
disclaimer here. I did not ring Srinivas and make him say that. Srinivas has this habit of bringing up such things. Anyway,
No, I'm being honest. So
that was not relevant. But anyway, thank you, Srinivas.
Fine. So now we move on to our next speaker, Dr. Varun Rai. He will be speaking on a subject called lasers in silolithiasis. Now, in the management of stones in the duct, within the duct, if it is a mobile, freely mobile calculus, generally between 3 and 4 millimeter size, it is usually amenable to removal by basket. Now, there are some stones which are bigger, which are stuck, either because the stone is very big or it is coincident with a stricture just distal to the stone, or sometimes it can be stuck at the hilum. Now, the hilum is the place where the primary duct goes, enlarges, and then becomes multiple branches. So that area is called the hilum. The hilum is seen both in the parotid as well as in the submandibular ductal system. So a stone which is, say, 5 millimeter and above looks invitingly easy to be removed with a basket if it is in the hilum. But then common sense, logic says a 5 millimeter stone will not enter a 4 millimeter duct. So it would be ideal in such scenarios to explore other options. And one of them is lithotripsy, that is intraglandular lithotripsy. Now, whether you use a hand drill, whether you use lasers, that is again dependent on your comfortability. I mean, your comfortableness with the equipment that you are using. Dr. Varun has a good series and good experience with use of lasers. So we thought we would introduce the concept of lasers to the wider audience. I now invite Varun Rai to give his lecture. He is an associate ENT surgeon in Sir Gangaram Hospital, New Delhi. Welcome, Varun.
Thank you. Thank you for having me here, sir. And hello, everyone. I shall be talking about the laser silolithotomy techniques. So the topic of stones being the major cause of obstructive sialendinitis, which forms almost 50% of the benign salivary gland disorders, needs no introduction. And this has really changed our approach, the Sialendoscope. It has brought about a paradigm shift from the gland excision approach to the Sialendoscopic approach. Unfortunately or fortunately, each stone and each duct is different, so our approach should be varied accordingly. When we come to the brief classification, and I've tried to keep this as simple and practical as possible, when we talk about the radiological or the endoscopic criteria, as Sir has just mentioned, the stones which are less than 3.5 millimeter or ones which are floating within the duct can be easily basketed and extracted. For the larger stones, you have a variety of approaches, which are the combined approaches, the fragmentation techniques, and of course, the gland removal as the last possible result. A major limiting factor is the palpability of these stones. If you feel the stone, generally the dictum is that you will be able to take them out. So these are a few treatment scenarios, and we see as the basket forceps retrieval for the floating stones. And we have the preferred approach, in my personal experience, to be the combined approach in the case of mid-ductal stones and the palpable large submandibular hilar stones. However, beyond this spectrum, we have the intermediate size or the non-palpable submandibular hilar stones, the parenchymal salivary gland stones, and small stones which are associated with stenosis of the duct, which impedes basket retrieval. And for these, the fragmentation techniques are typically useful in my experience. So the fragmentation techniques could be external or intracorporeal. We have the ESWL. Well, at least in literature, I haven't had the pleasure of using it. And we have the pneumatic or the laser powered lithotripters. Again, the pneumatic is still in development. I've not had personal experience, but laser, yes. So throughout history, since it was first introduced by Gunlach et al. In 1990, there have been a variety of lasers which have been deployed for this particular use. However, after reviewing almost all the literature, the Holmium lasers are usually preferred due to the easy availability, since our urology colleagues already have it in most of the hospitals. It has a high fragmentation rate, regardless of the physical and the radiological characteristics. And it's a relatively lower cost laser. However, the holmium laser is known for its lateral tissue damage and the thermal damage. And these are potential concerns that we need to address. Now, when planning a laser silendoscopic case, we have special considerations. We should have a consent for an adenectomy. The stage procedure is sometimes a requirement. I will get to that. And the recovery is typically delayed when you compare it to a combined stone extraction. And of course, there's the problem of we don't have a stone to show the tendon. So the satisfaction factor does go down. Choosing the right equipment is paramount. Now, I personally try to use the smaller laser fiber for the smaller stones. And as the stone or the duct size increases, I can increase the size of the fiber. I prefer to use the all-in-one system for my laser. And the all-in-one system has two varieties, which is the Marshall system and the Erlangen system. The Marshall system has a small bend, distal 5-degree bend. Now, while using a laser, you really need your fiber to be end on and you should be completely oriented. With this 5-degree bend, sometimes your laser fiber and the laser beam can hit the ductal walls, which can cause a catastrophe. The laser machine, yes, of course, there are various companies producing it, and every company has a different criteria. I personally have been fortunate to use the luminous laser, which has the characteristics of less thermal damage when compared to the other ones. So in our experience, we used all these limited inclusion criteria, and we've done 79 cases up till now. And this is a brief technique, video about the technique. So the first step, as with any other silendoscopy, is first gaining access to your duct, where the papilla is dilated. Now, a couple of things which I want to point out. In a laser case, you end up using a lot of irrigation and you have a lot of fragments to deal with. So I typically overdilate the papilla. Here we can see that we are passing the scope along the guide wire, and we see a small stricture segment here. Once we bypass that with our scope, we see a small stone which is floating behind the strictured segment. Now, the easier option, the relatively easier option was to first basket and try to force it out, which did not obviously succeed in this case. So the next option was to dilate this segment using the balloon, hoping that it would dilate even temporarily enough to facilitate the extraction of the stone. However, on repeated basketing and ballooning, it did not really work. So we were left with options of either a combined approach for a really small floating stone, which is going freely in and out of the duct or of the gland, or using the laser. We preferred using the laser. Now, when you do a fragmentation of the stone, it is important to stay in the center of the stone. You should not be in contact with any of the ductal walls, because there's been enough studies to suggest that there's a lot of damage caused by heat absorption into the duct. We are also aware of the fact that there's a lot of reflected energy of the laser, of the stone. So we try to manage our exposure of the laser as less as possible. We do start with the lowest possible settings of the laser as well, and try to keep it at a lower frequency to limit our thermal damage. So as we see that the fragmentation is going on progressively, the debris is washed away with concomitant irrigations. And eventually we see this Swiss cheese appearance of the stone, which shows that it's working. After breaking down the stones into manageable pieces, these are extracted one by one using a basket or a forceps, as the need may be, leaving us with a nice clear duct at the end. And you can see the basketing being done. And this is the last of the stones. I'm using the tipless basket. As you see that there's not enough space behind the stone too. And you see a slight tug which we have to give, and that's it. And that's the last piece of the stone. So I will be skipping the papilla preparation since it's already been discussed in detail. However, with powered instruments, there are a couple of dangers which have to be addressed. Of course, there is a learning curve, and you should be proficient in first doing a diagnostic endoscopy as well as a basketing before you attempt doing a laser, and case selection is paramount. And these selection is basically done intra-op, whether a laser is feasible or not. The inherent problems of thermal damage is there, which are the direct problems which can lead to ductal perforations of misfiring of the laser. And you could have the late stage stenosis because of excessive thermal damage. And you have the indirect problems as well. There is also a problem of the laser causing stone retropulsion and subsequent migration into the tertiary ducts, which may lead into further stone problems at a later date. And papilla damage is one of the major things. This is one of the laser cases, one of the early ones, and this is in a 5-year-old child, where we had a 3.2 millimeter stone. And after a successful laser, and this is the last piece, which this thing, and it migrated into the tertiary duct. Now, keep in mind, I'm using the modular scope for this case. And you see, once I'm trying to chase the stone and going into the tertiary, you see there's a slight give. And as Dr. Shirish mentioned, one of the dreaded complications is degloving of the duct. And here you can see, if I just pause it here, that's a duct within the floor of mouth mucosa. So I had to do a cut open approach, expose the entire floor of mouth and trace the duct. And fortunately, I was able to bring it forward and create a new papilla. And this is 6 months post-op where the child is absolutely fine now. And this is the papilla. So in results, I would like to divide it into 29 initial cases and the 50 rest of the cases. In the 29 initial cases, we saw that we were able to fragment all the stones. The symptom resolution early phase was 96%. However, when we tracked these patients down over 3 months, it was 62. So what exactly went wrong? We did endoscopic examinations of all these patients, and we saw that there were remnant stones, fragments, which were left behind, which may have migrated earlier. Or we could see the stenosis, which could be early or late stage stenosis. And this prompted us to rethink our strategy. And we did a recently concluded study where we took 50 cases who were followed up over a longer period of time. And they were subjected to serial OPD-based local anesthesia endoscopic evaluations. And we would manage these small problems of fragments and your stenosed ducts in the OPD and replace stents as and when required, which brought our overall success rate to about 92.8%. So when we revisit our review of literature, now our study reflects a more realistic and a comparable data according to all the worldwide literature, with the benefit of having a longer study duration. So just to conclude, some tips and tricks: we should always have a backup option, be it a combined approach, a ductal exploration, or an adenectomy. A thorough knowledge of anatomy is a must, not just papilla and your endoscopic skills, because things can go wrong at any point of time. Another point which I would like to highlight is not to attempt laser without proper instrumentation, and which means you should have the entire set of dilators, at least 2 or 3 scopes, and every instrument needed to manage all your complications. Irrigation protocols is something that we follow. As a general rule of thumb, I make a cutoff limit of about 80 ml for my submandibular and about 100 ml for my parotids, because excessive irrigation can lead to leakage of the irrigation fluid into the loose floor of mouth tissue and can cause airway obstruction due to pushing the tongue backwards. And the assistant protocols are basically someone who keeps a track of the amount of irrigations that we have used, and also to watch for any impending edema. We now can say that we always follow up, and all these laser endoscopies should be followed up with serial endoscopies. And we should recognize complications or potential problems early and treat accordingly. I'll just leave you with a nice normal healed duct of a post-laser patient. And this is a endoscopic examination after 1 year of his laser treatment. And here we can see the jagged edges and a dilated segment where the stone bed was. And we see a nice healed tertiary ductal system, and the patient is completely asymptomatic. in the end, I would like to leave you with this scary image that yes, laser is a dangerous tool, but of course, we all expect it to cure the patient. Thank you.
Thank you, Varun. That was a wonderful presentation. Now, a few questions.
Yes,
would you prefer a 1.3 scope or a 1.6 scope for your laser use? Because you are largely doing fragmentation of the stones and then retrieving the stones. If you would like to use a forceps, I suppose you will have to use a 1.6 scope.
Yeah. Yes.
So when would you use a 1.6 scope and when would you use a 1.3 scope?
So my workhorse has always been the 1.3 all-in-one because it provides some potential space around the scope so that the fragments do get washed away from time to time without me having to manually remove them all the time.
Mm-hmm.
Second, the forceps I have found, yes, it is invaluable in certain conditions, but only certain conditions. Most of the conditions, the basket is sufficient. So unless I really encounter a situation where I need to deploy a forceps, I would prefer using the 1.3.
So now supposing there has been a damage by the laser shot to the wall of the duct, and then you have edema of the floor of the mouth developing, would you abandon or what else would you do?
All my patients, I've always taken consent for a stage procedure. Any of these signs, I would abandon immediately and come back another day.
Okay. Dr. Imad? Dr. Imad? Okay. Now, supposing you encounter a floor of the mouth edema while you're dealing with a submandibular ductal stone, would you abandon the procedure or would you do something else?
Well, there are a couple of...
No, not Varun. Varun, sorry. I'm asking Dr. Imad.
Sorry.
Well, the problem while dealing with a submandibular case is obviously there is a potential of getting a dreadful complication, which is Ludwig Angina. I haven't seen that before, but if it happens that you perforate your duct and the assistant is always putting in pressure, that's what you exactly kind of get. You get a floor of mouth edema that can transfer your case to an emergency for airway compromise. So the general rule of thumb, especially for beginners, is that if you're having a perforation, especially in the submandibular gland, you should stop at that site and make sure that you don't get a dreadful complication of airway compromise. When you're doing a parotid case, you have a little bit more margin of not getting yourself into an airway compromise scenario. So generally, I prefer, when I was first beginning, when I'm finding that there is a perforation, you should generally stop. For more experienced surgeons, they can get around with a small perforation and decrease irrigation and go on and complete the case or do a combined approach or whatever. But generally, I prefer to stop.
Okay. Do you have any experience with lasers?
No, actually, I don't use lasers, although they have their place in the armamentarium of managing cases, and I'll show that in my presentation. But generally, I don't like to use lasers. The problem with using lasers, as Varun said, is first of all, it can be very time-consuming if you're trying to fragment a very big stone. Second, you can get some complications from perforations and from false passages and even from post-operative duct stenosis from injuring the duct. And third is the expense. You have to put also the expense as a factor. So generally in Egypt, we don't use lasers a lot. Even that we have lasers used our urology colleagues use it a lot, but I think the spectrum of use is there, and the factors playing in are different than in Sialendoscopy.
Now, I had the experience of seeing your combined modality of imaging, both CT scan and MRI protocol of yours, which was very impressive. Now, what would be the protocol that you would follow in a patient with Sjogren's?
Well, Sjogren's, I think the MRI cellography would help a lot. As you said, we have this protocol in Alexandria. We first do a preliminary ultrasound and see what you get. The problem with ultrasound is that it is user dependent. Sometimes you get very good reports, and sometimes you don't get that good reports. Then we do a combined CT MRI cellography procedure, a non-contrast CT and a MRI cellography. The beauty about that is that the CT gives you the exact location of the stone, the number of the stone, but it doesn't give you a lot of information about the duct. The MRI cellography gives you the exact location of the stone, the condition of the duct, if there is any strictures. It shows you everything related to the duct and the exact position of the stone. So if you combine both of these modalities, you can get a very good roadmap for working. Specifically for Sjogren and for recurrent juvenile parotitis, you can actually know the exact extent of the disease with an MRI cellography, and you can know the key points that you have to tackle if there are any specific strictures you have to tackle. So, and again, MRI cellography helps a lot in that.
To plan. Yeah, thank you. Now, a question for all the panelists. How many of you do your surgeries under only local anesthesia? Please raise your hand. Okay, Dr. Anand does most of his Sialendoscopies only under local anesthesia. All the others prefer general anesthesia. Now, under general anesthesia, a few dictums. I think all of us follow nasal intubation.
Yes. Only for submandibular cases.
Only for submandibular cases, which is obvious because the tongue has to go up. Yes. Okay. Now, with respect to another question, how long do you wait for conservative treatment before you actually move on to Sialendoscopy?
What is the indication? What is the indication?
I think Sialedinitis. Question is how long we give conservative treatment before considering Sialendoscopy. I think you can probably
probably before the patient comes to a Sialendoscopy surgeon, he has enough of
conservative treatment.
Correct.
I think the dictum is the two Sialedinitis of the same gland. I think is a reason for us to think about Sialendoscopy, isn't it?
Yeah, in 6 months, 2 attacks.
I have something to add to laser.
Yes, sir. Please.
I'm using quite a lot of laser, and I think you asked about the size of the scope which you would prefer.
Correct.
So it depends what size fiber you are using, and it's really a beautiful instrument once you get used to. And I think Professor said that it is time consuming, but not so. It's just initial part like Sialendo. Later on, it becomes quite quick. You need to know the settings. Initially, when I did almost my 10 cases, my urologist friend was standing with me. He would change the settings, and now I know the settings what to do, because the main part of the stone, the consistency, has no investigation which will tell you. It's only once you go in, you know how consistency of the stone is, whether it is very hard, very soft. Accordingly, you can change the settings.
Correct.
And when it comes to removal of the stone, you can change the scope to a bigger one, which would take basket, or which would take your forceps.
Okay.
So that is one. Secondly, I wanted something to add to Dr. Anand. He mentioned about measuring the depth of stenosis, which he said is possible only with compact scope and with the stent. But I differ with that. Even with modular, I measure it. How? It's very simple, because all the modular channels have same length. Once scope, your channel is inside, just take another channel and compare how much part is outside. I actually take a scale and measure the outside part. And then you can easily measure even with a modular scope. I routinely do it.
Okay, those are all good practical points. Now our next speaker will be Dr. Methylene sir. So for the time being, I'll move on to the other panelists. Dr. Imad wants to add something. Dr. Imad?
Just a very quick remark there. Actually, two very quick remarks. First of all, we've been doing an interesting study of measuring the density of the stone using Hounsfield units by the CT scan. And we found that you can actually preoperatively know the density of the stone and show how whether this is a soft or a hard stone, and that can be of influence in detecting whether or not you can break your stone easier. So that's one remark. The second remark, when I said that it is time consuming, I was talking about not the 4 or 5 millimeter stones. I was talking about maybe trying to get a 7, 8, 9 millimeter stone and break that down. I've seen Francis Marshall take like 3 or 4 hours in trying to break big stones, and I'm pretty sure now he has stopped doing that and reverted to combined approaches, because it takes a lot of time and you can get more problems. But again, I praise Dr. Methylene and Dr. Varun for using the laser, because I think it has its place in the armamentarium of Sialendoscopy. But the one word of caution I don't want to people to get into is that if you have a big stone, try to break it down, because that doesn't happen in all cases.
Okay, thank you. Now, Varun, before I bring you in to rebut, how many of you have experienced a basket breaking in the duct after it has entrapped the stone? Okay, Varun has encountered, Aditya has encountered, Sirish has encountered, Anand sir has encountered, Methylene has encountered. Bini, what did you individually do? Bini.
Srinivas, just a point. I think you need to take a look at the watch, because we have 3 or 4 speakers still.
I think they will extend, don't worry. Bini. Quick, all of you need to be quick.
Yeah, it is actually a combined approach. Where it got tugged, I had to open it there and release it. That's
and
what
then
I
you
had
put a
done.
stent.
Yeah, put a
And
stent.
then, so Dr. Anand? Sir, unmute.
Unmute.
All of
Basically,
you unmute.
it is not a basket that is breaking. It is basically a basket that got locked up.
Correct.
It doesn't release the stone. In that case, like Bini said, sialendocotomy, take out the basket through the hole we made, release the stone, and pass a guide wire, and then pass a stent.
Dr. Methylene.
Yeah, what I did is I did like a combined approach. I took an incision there, but instead of taking out outside, I cut the basket off and retrograde, just removed the basket. That was easier.
Okay.
That's the simplest way you can do.
Dr. Aditya.
Yep. We have had both the basket breaking, but the advantage is if one of the wires of the basket breaks, the basket comes out. Basket getting stuck with a stone, you may convert immediately a combined approach and sort it out.
Okay, Varun.
In a couple of cases, I've had this happen to me thrice. One, I had to convert to a combined, but in 2 cases, what I would manage to do was sacrifice the basket by cutting it, taking a smaller scope, putting it on a guide wire or a microburn, trying to disengage the stone from the basket. Sometimes it works, not every time, but it saves the hassle of a combined approach.
Okay, Dr. Sirish.
Yeah, I did a combined approach, because my basket broke right at the end where, right where it begins. The remaining of the basket came out, but the basket cage entirely had broken in and stayed in.
Okay, now does the breakage of basket has anything to do with reuse of the basket?
Yes.
So when you reuse, it can happen. So preferably it's disposable. Okay. Then now we move on to our next speaker, who is Dr. Methylene Navlake. Methylene Navlake doesn't require any introduction. He's a multifaceted ENT surgeon from Mumbai. He runs a training course in CMAST for Sialendoscopy. I think he does it twice a year or even more frequently if there is a demand. So all the viewers who are interested in learning hands-on can probably contact Dr. Milind for that. He too is a sought-after faculty for Sialendoscopy all across India as well as abroad. He is currently the Vice President of Sialendoscopy Group of India. I now welcome him to deliver his lecture. Welcome, sir.
Thank you. Thank you, Srinivas, for the wonderful arrangements here and a good, nice introduction. I think I would go on to my screen. Okay, as we have been talking about management of stones here, I think most of the time a question comes that what size stone. So as it has been already discussed that consistency has a lot of it to do with size of the stone as well as its location, which matters. So I have had difficulty with a 4 millimeter stone, and I could remove sometime a 2.5 centimeter stone if it was just friable. So we are talking about large stones in submandibular gland. Large stones in India somehow are very, very common. We have such a large population, and we have so many other things to deal with, so that the minor complaints most of the patients would ignore. Coming straight to the point of large stones, we have been doing this for ages together, that cutting the duct at near the ostium, especially submandibular, and taking out the stone. Now the same can be done even in Sialendoscopy era. I would suggest just a small correction in that. You use a scissor which has a ball tip here, as you can see, and obviously the angled forceps would help you there. In addition to this, I hope this runs and you can see. In addition to this, duct slitting where the stone is very big, I'm sure that Sialendoscope, there's no place for it to introduce also in this. And once you remove the stone, which is quite big, it is definitely a good idea to pass the endoscope and check the duct. That's because many a time we found that there are small stones inside which are behind, which are radiolucent, and they were not picked up on any of the radiological investigations, but with Sialendoscopy we could remove that. Now this is quite an age-old procedure which people have been doing, but if you see the difference, if you do it under microscope, and the first step to learning Sialendoscopy is respect the papilla. So once you respect the papilla, whether it's a large stone, whether it's a small stone, then definitely you can do a good Sialendoscopy. I think I'll just run this little fast with lack of time. Yeah, that's the large stone which people have been doing from ages. The same patient, you do a diagnostic. Now what are the challenges when you try to do diagnosticoscopy in a duct which is already split open, such a big stone removed? See, the amount of irrigation which I would require would be very, very high, because there's nothing is remaining inside. It's no more a closed system. It's an open system now. So my assistant, instead of at a rate of 5 ml whatever, he would go on to 20 ml per minute or so. So this is how you can see here. There's no residual stone in this, but it is definitely a good idea to check. That is how you see it next day. Now, when you remove such a big stone, it's not a must that you put a stent, because you can just simply marsupialize and achieve a good result. That is a stone size. Now, most of the time you would notice the big stones in submandibular are hilar. So any stone which is more than 5 millimeter, 6 millimeter, hard calcified and at the hilum, they are definitely quite difficult. But the main criteria, as I think Varun mentioned, that if you can palpate it, then it's usually removable. If you cannot palpate, then it may be difficult. If I have a small stone at the hilum, could be more difficult with the technique which I follow, rather than a big stone. Big stone at the hilum you can definitely remove. So why do you have stones which are very big at the hilum and patient do not report to you? There's a physics to it, that as you see in this picture, if imagine this as a duct. Now this is a straight part, this is the hilum. So for in the main duct, you require a very small size stone to actually block the duct, that the red line which you can see. But if it is at the hilum, there you require a large stone to be formed to actually block the duct completely. So these are the different stones which have been removed from the submandibular. As you can see, most of them are amenable to a combined approach. And as somebody rightly said, that gland removal, I think I almost stopped doing any size of the stone. Now I don't think anybody showed, so I just added this slide just now. Use of drill. Now a lot of newcomers would ask me which drill to use. There's no separate drill machine as such. These are handheld burrs which are available in two sizes, 0.38 and 0.68. As you see, these are two burrs, and if you see them in full length at the other end, as you see, you can hold this and just rotate with your hand, and you can use the burr. I'll show you the use of burr for large stones in submandibular. Now, if you compare the time for burr and laser, obviously burr takes less time, but burr requires the stone to be fixed at one place. Whereas with laser, even a big stone which is not fixed, which is mobile, you can break into pieces. Now here, as you see, this was a big stone which was fixed at one place. I don't know for what reason, but this is just repeating the videos. Okay, so coming to combined approach. Now combined approach, we are talking here in submandibular, rather than, I'm not talking of parotid today, but Sialendoscopy, it would be obviously an intraoral incision along with Sialendoscopy. Basically, you need to get a good access to the proximal part of the submandibular duct and the hilum. Now, how I do it initially, firstly the intubation is definitely nasal. Before even you intubate, you can palpate and make sure that where the stone is, because once you start doing Sialendo, then it may be with the fluid irrigation, it may be difficult to palpate. Now when the duct curves at the posterior end near the mylohyoid, that time it lies more superficial in the mouth. Identification of the lingual nerve is very, very important. And primary closure of the duct sometimes is possible, sometimes it is not. Lingual nerve, if you cut or damage, the patient will curse you for life. I had a patient who's Supreme Court judge on a panel of judges. He said he has been to 10. I probably feel that some Sialendoscopy surgeons also, and 10 ENT surgeons. And he said, if you give me a guarantee that lingual nerve you will not damage. I said, I cannot give a guarantee, but I can tell you I've done hundreds, and you should have a good chance that I would not damage. And luckily we could just remove a very, very big stone there. I think that's the same patient for whom he said, absolutely, he's a very demanding patient, but I took the challenge and we did that. The big stone here, as you can see, the stone is quite big, was palpable. I could see the duct before that, so it was definitely within the duct. dilate the papilla as you do in any other case. Now, whenever I palpate, I definitely tell my assistant also to palpate. So, we are in together. While doing this, all the intraoral part has to be done under the microscope. Now, what I do is when I'm doing under microscope, my assistant also watches on the monitor. So there are usually two monitors, one in front of me, whether it is Sialendoscopy or whether it is microscope, and one behind me so that the assistant doesn't have to turn the neck and continuously watch. As you see here, we take a small incision, go along the duct, keep on palpating repeatedly, usually with a little finger, because being in smaller in size, you can easily go inside and check. Lingual nerve is much thicker and anterior than what you imagine. It's not a must that every time you'll find it, but if you are careful, I'm sure you would never damage it. If you require, you can in between increase the magnification. Another thing which was done here is I always take a tongue stitch rather than continuously retracting. Just take a tongue stitch and retract the tongue on the other side, which definitely helps. That's quite a large stone there. Here, if the stone breaks, then you are in trouble. But there also we have a solution. What I do is once the stone is out, don't be thrilled. Rather, concentrate onto your duct and cannulate the duct immediately so that you don't lose the other end. Once you can see the opening there behind, immediately you can put either a stent or this is my assistant who is using the angle forceps. As you can see here, can you see the stent? This stent we had already put it from the duct opening, and there was a guide wire also. So immediately I could put it into the distal part, the proximal part of the duct. Now, whether you suture behind or not, I've seen multiple cases. Even if you are not able to suture, but put a stent here, you see after 2 months, you will have a normal saliva coming from this. It just heals naturally without any issues. Till now, there was only one patient who was a radiologist himself. He said, I can feel the saliva coming behind my trunk. I said, is it bothering you? He said, no. Then said, just forget about it. Because there must be some leak there. And he still had a good flow from the main duct, the natural ostium. That's at the end of the procedure. I always flush with steroid. Sorry for this, but I don't know why this is just repeating on itself. Oh, sorry for that. I need to share again. What happened?
I think if you are not done with your talk, you still need to reshare it.
Yeah. I think I'll go onto the slide and then start again. I'm about to finish with my presentation that way. Hardly any slides remaining. Okay, there was one thing which I Just wanted to let you know. There's another case, but Srinivas, I think it's a repetition, so I would just skip the second video.
Fine.
I would rather spend more time in discussion.
Okay.
So another thing, whenever such cases are there, I make sure that I inform my radiologist to be around, and it helps most of the time, because if I am at lost and can't find second part of the stone or some piece from there, then what? Can you see the screen or no?
No, sir.
1 minute. Sorry for that.
Sir, if you don't mind, can we move to the next thing in case we need to come back during the discussion? You will be able to show it.
It's done.
Yeah.
I'm here. Yeah. Can you see now?
Yes, sir.
Okay. So the role of intraoperative sonography. The intraoperative sonography is very important, and it helps in locating your residual stone. The challenges with sonography. Can you see now?
Yes, sir.
Okay. The challenges with sonography intraoperatively is because the duct is not at normal position, and since you are irrigating, it's little difficult for the radiologist. But most of the time, they would be able to tell me whether I'm 2 millimeter, 3 millimeter away from the stone. Okay, so these are the challenges, and usually once you have only one radiologist coming with you every time, that would be definitely better. So standard steps have already been discussed, and most important I would suggest is preserving the lingual nerve. So with this, I think large stones, you can still preserve the beauty of the face without even a scar, whatever is the size, but be cautious while doing about the nerve. Thank you very much.
Thank you, sir. Can you stop sharing your thing, sir?
Yeah, I've done that.
Yeah, thank you. So basically what we need to be aware of in a combined approach is the relationship of the lingual nerve, the submandibular duct, and then the floor of the mouth.
Yes.
So you need to be aware that the lingual nerve is inferior and the duct is a bit superior in the floor of the mouth.
Yeah, because you are going from inside and not
yes,
like
sir.
what you do in the submandibular gland excision.
Correct, sir. So the crossover line is the M1, that is the first molar. That is the place where the nerve actually crosses over from the duct. The duct is above, the nerve is below.
Yes.
This is the lingual nerve, which takes a curve very close to the third molar. So that is a very good depiction of its relationship to the third molar. If you're making an incision here to reach the hilum, which is here,
yes.
So you will generally be able to see the lingual nerve.
Yes.
So that should be it. So I just wanted to bring out those points.
Srinivas,
Yes,
I usually don't do this. You know, this looping, if you do a looping of the nerve, there are more chances, even the stretching can cause similar damage. So I would rather just leave it, take it in one of the retractors and not put a loop around.
Loop. Mm-hmm. Now this particular case, which was there on the video, it was a 5 mm stone, no, not even a 5 mm, 4 mm stone in the secondary duct.
Oh.
So we had to identify it endoscopically, pass a guide wire. We had to move around both with the duct as well as the nerve so that we don't injure. And it was actually quite a struggle for us to remove it. If you would like to see that video, I can show that video. But I think we are short of time. Let's move forward. Yeah, I think a lot of people want to get involved with the discussion. So Dr. Anand, Dr. Imad, then Dr. Aditya in that line.
Okay, for retracting the lingual nerve, I believe like what Naulake said, and the instrument of my choice is a tongue depressor, the opposite end of a tongue depressor, a metal tongue depressor. It works beautifully to retract the lingual nerve away from the duct.
Correct, sir. We also do the same.
There is a better instrument. I will tell you, very, very cheap, less than 1,000 rupees for 3 instruments. A set of 3 malleable copper retractors, which our local Kalelkar has.
Okay.
And you know, believe me, I have 3 sets of it. So whichever size, whatever I want, just bend it, retract. Next time, just use that. You would be very happy.
Thank you. Thank you. Dr. Imad.
Well, thank you very much, Dr. Millen, for this very interesting presentation. Let me share with you in 1 or 2 minutes maximum another way of retrospectively doing my tips and tricks for combined submandibular approach.
Dr. Imad, if I can interrupt, you are the next speaker.
Okay.
So before you start your lecture, can you show that video at that point of time?
It's not a video, it's just a few comments.
Okay, fine.
Okay.
Yep.
First of all, I say that the most important thing in this kind of operation is the assistant.
Yes.
Because the assistant has to push on the submandibular
gland from outside,
and that helps you a lot.
Yes.
Second, I never use stents in these cases, especially if the stone is very big. The mindset behind that is that the duct is hugely dilated. So I don't use a stent unless if I find there is a distal stricture or something that I need to put a stent in. Yeah. Third thing is that when you're closing your incision that you made in the floor of the mouth, try to make this closure loose. Don't make a very
so that there is a leak of the saliva from there.
Yeah. Yeah, because if it God forbid it happens that there is a salivary in there, that would help you. It won't make you miserable.
You want a fistula to form there.
Yeah, exactly. But again, these are some points that I wanted to just share, and maybe somebody would benefit from.
Okay, Dr. Aditya, quickly, your
yeah, about the loop. We routinely use copper malleable retractors, lovely instruments, orbital surgery, periorbital surgery. They have their limitations. What Dr. Anand says, the curved smaller end of the lax tongue depressor, brilliant instrument so long as the nerve has to be retracted in one position. The reason and the occasion where we use the vein loops here is very simple. If the nerve has to be retracted in multiple areas, this is open surgery. I use the same nerve retractor when I operate to remove the submandibular gland transorally. One thing I have to say is since we operate a lot around the lingual nerve is far more robust. It recovers from its temporary paresthesia extremely quickly. And I have no hesitation in using this. However, to each his own, all of it works well, especially Dr. Anand's, the curved end of the lax tongue depressor is quite brilliant. But in major surgeries where the duct and the nerve have to be separated repeatedly on both sides and dissection has to be done, I stick to the loop.
Okay, no more discussions. We are supposed to stop the talk at 2 o'clock. They have extended it by 20 minutes. So no more discussions. Let us first finish the lectures. At the end of it, if we are having some time left, let's fight it out. I now invite Dr. Imad Maghdi, our guest from Egypt, who is a professor of otorhinolaryngology, head and neck surgery in the as a university faculty of medicine in Alexandria, Egypt. I thank him for having patiently waited on a festival day. Today is his Eid, and he would have rather been with his family. We should be thankful that he's spending his time with us. Combined Sialendoscopic or mini preauricular microscopic approach for large parotid stones is his presentation. I now invite Dr. Imad to deliver his lecture. Welcome, sir. You have to unmute. Dr. Imad, you have to unmute.
Do you see my screen?
Yes.
Thank you very much. I'm really feeling honored and privileged to be the only one out from India joining in this very interesting webinar. I've learned a lot so far, and thank you again for having me. Well, I'm going to talk about today a specific issue, which is tackling large proximal parotid stones. And just to keep you in context of what we're talking about, this algorithm is used for salivary duct stones. We know that less than 4 millimeter stones are easy stones, and these you can tackle with Sialendoscopy using a wire basket, as been said. More than 8 millimeter stones, these are usually palpable stones, and these are again easy, and they can be tackled usually by the combined or what we call hybrid techniques. And the most difficult are the 4 to 8 millimeter stones. These require what we call lithotripsy, and these are usually more difficult techniques. The methods of stone fragmented have been covered. You can either have the ESWL, extracorporeal shockwave lithotripsy, for extracorporeally breaking down stones. You have endoscopic lithotripsy techniques using laser, handheld micro drill, and what we call the Stormbreaker system. The ESWL has been covered before, so I'll skip that. The main problem with using it is that it requires multiple sessions usually, and the main problem is that you have to do another Sialendoscopy after that to clear the fragments. Laser lithotripsy also has been covered, but I'll focus on the problems of using laser. We said about lateral thermal damage can lead to ductal stenosis, long operative time, especially in big stones, more than 7 or 8 millimeters in size, and the generated heat can also damage your scope. So you have to put that into consideration. The handheld, I think somebody also showed that you can actually fragment soft stones. You can't do fragmentation of harder stones using this handheld micro drill, but again, this is a very cheap instrument you can use for just breaking down some soft stones. As you can see here in this video, you can see that it can actually break down these stones into smaller fragments that you can actually extract. But again, the problem is that it is not always useful in large spherical and hard stones. This Stormbreaker system was developed by Cook Medical. I have no conflict of interest to disclose, but it actually does like a pneumatic gas-driven pistol that can break salivary stones. I don't think it is used a lot now. It didn't, I think, gain FDA approval. And the problem with that is that it actually can put on force, and that can perforate the ducts easier, and especially if the stone is impacted. So let's focus on the topic we're going to talk about, is the combined external parotid approaches. These are actually have been present now for quite a while. You can do actually your external parotid approach either one of two things. You can either do a direct transfacial incision over the parotid duct, which was first reported by Nahilili in 2002. The problem sometimes with that is, especially if you're having a young female, sometimes these have anesthetic scars, as I will show. The other way is to do a standard parotidectomy or facelift incision with creation of a U-shaped smash flap. I think Dr. Ayata will be talking about that. And this was originally described by McGurk in 2006 and later modified by Marshall in 2007. The problem with that, in my opinion, is that you have to do like a standard parotidectomy operation with its surgical burdens. So just to give you a clear view on the combined parotid stone approaches, the idea is to try to localize the stone using a standard Sialendoscopic technique, and then to extract the stone not from inside the duct, but externally via an external incision. And I like to prefer to use a mini pre-auricular incision, and then to actually do a microscopic assisted technique to remove the stone externally, as I will show. So this is an example of a case. This gentleman had this big stone in his left parotid duct, and you can see the stone here. It's almost 14.6 millimeter in 7.5 millimeter stone. It's a big stone, and you can see even in the CT, you can see some dilatation proximally in the duct. So first, we do like a standard procedure and try to identify the stone using the scope. After we identify the stone, we leave the scope in, and an assistant takes care of that, as you can see. And then we take like rolled towels and secure that scope in place. And then, as you can see, we follow that light. So that light gives you the exact location of the stone. Then I shift to the external approach, which I like to camouflage in the tragus, and then do a very small incision just in front and below the ear lobule, rather than doing a standard facelift incision or a parotidectomy incision. So this is the very small incision you use, very neatly camouflaged. And as you can see, you can actually reach, from this small incision, you can reach the area where the light is. And you can see here the scope is in there, fixed in position. And this is the light. And you can see when under my operating microscope, I'm actually dissecting the hugely dilated duct, as you can see. And you can see the light of the scope inside the duct. And this is the duct. Another thing that is very useful from the operating microscope, you can actually see the branches of the facial nerve. And you can see here we're extracting a very big stone. This was about 50 millimeter stone from this small incision and getting that stone out from that incision. Okay, sometimes we like to use stents. But again, as I said previously in a comment, I only use stents if there are distal strictures in the duct that I had to dilate when I was localizing my stone at the beginning of the procedure. But if that is not present, I don't use stents in these cases, because again, the duct is hugely dilated, so the stent has no meaning. And I like to meticulously close the duct using 7-0 or 8-0 Prolin strictures. I've been trained in microvascular surgery, so I'm very used to closing these ducts very meticulously. And after that, you can irrigate to see that if you acquired an actually watertight closure to prevent any salivary leakage after the operation. And if you're going to put a stent, this is actually the stent in place. And again, I reserve that only for strictured ducts distal to the stone. And this is the incision you can see. Again, I like to use Redivac suction drain. I know that some people avoid that use, but again, if you're closing your incision very well in layers, first of all, closing the duct and then approximating the tissues before or after you close your incision, the Redivac helps in preventing any hematomas. So this is the stone extracted. So the advantages of using the operating microscope in this case is the higher magnification and accentuated illumination compensates the smaller working field. The facilitation of the periductal facial nerve branches identification, as I said before, and that can avoid you be using a continuous neuro monitoring of the facial nerve. So you can only use just like a nerve locator or a hand nerve locator rather than having to use an M or a continuous nerve monitoring. The operating microscope also helps you in meticulous microsuturing of the Stenson's duct after your cellulithectomy. And here is the patient after the operation. You can see that the incision is very neatly camouflaged. You can't actually see the incision in most cases. This is another case. You can see here, this is a very proximal stone, which has like a Y shape. And somebody talked to me about our protocol in the MRI CT scan that we use. Here you can very nicely see that you don't have any strictures in the duct. And even though that this is a very, very proximal stone with a very unfavorable anatomy. You can actually preoperatively, if you have an MRI Sialography, you can actually know that you would be able to reach this stone successfully without having problems if you have that MRI. But again, as I said in previous meetings, believe it or not, the CT and MRI protocol that we use in Alexandria only costs the patients about $50 to $60 US dollars. So it is very pretty cheap in Egypt. So that adds to the cost-benefit ratio, which I'm sure is not the case in a lot other parts of the world. So again, you can see this is a very, very proximal stone, and as I said before, with a very unfavorable anatomy. I won't go with that with a laser, even the stone is not so big. So as you can see, we're going there, doing the incision, and again, a very, very small camouflaged incision. And we follow the light until we find the duct. Okay, and this is the stone. It's like almost a Y-shaped stone. The third case, here there is a rounded stone. Again, these rounded stones are much more difficult to extract because when I'm asking my radiologist to give me the information pre-hand, the radiologist tends to give you only the larger diameter, and that doesn't help us a lot, because if you have a stone that's maybe 7 or 8 millimeters in length and 2 or 3 millimeters in width, that would be a little bit easier than if you have a 5 millimeter rounded stone, because the diameter that you have to extract is all the 5 millimeter from a 4 millimeter, so that would be difficult. Okay, so that's the same thing. I like to actually put an X there. And I like to use these self-retaining retractors. You can see that it helps us a lot from this very small incision. And you can see here the tip of the scope, and you can see the stone from this small incision. And again, the beauty about it, it's very camouflaged, and the patients are very happy. And this is the stone, about 5 or 6 millimeter rounded stone. And again, you can see here, the incision is barely noticeable. This is the last case. This is a very interesting patient. He had actually 2 attempts of a transfacial
Hello. Hello. Dr. Imad?
Stone, can you hear me?
Yeah, now we can hear you. Yeah, we can hear you.
Yeah, so that patient had 2 attempts, previous unsuccessful attempts done elsewhere, one of them was using a C-arm. And you can see here this kind of bad, ugly incision that was done transfacially for this gentleman. And we actually did the same technique. And here I said, well, okay, we'll do a scar revision at the same time and actually go from this transfacial incision in order to get this big stone. So this is like just a revision of a series we've been doing. I've been using this technique. I've been doing Sialendoscopy for almost more than 10 years now. I've been using this technique for the previous 5 years, and we did 19 cases in that. The age range was from 20 to 68 years. More were females. Stone size ranged from 5 times 5 to 16 times 8 millimeter. And most of them had single stones, but a few had some multiple stones. We used stents in only 4 out of the 19 cases. That's almost 1/5 of the cases. So not routinely using stents there. Complications, we only had 2 cases of wound seromas, and these were managed by aspiration and compression dressing. And all patients had completely intact facial nerve function post-operatively with good parotid salivary flow after a median of 26 months. We've actually submitted this case series to laryngoscope, and it's under review now for publication in the Linguoscope journal. These are some of the stones we actually are showing in this case series. You can see a magnitude of different kinds and different shapes and different consistencies and even different number of stones. So to sum up, I started first by showing the algorithm. So now I show a new algorithm for parotid duct stones. You can see this middle part is missing now. This difficult part is missing. If you have a I now personally like to use, if you have a smaller stone than 4 millimeters, so go with using a wire basket. If you have a more than 4 millimeter stone, it's also an easy case using this combined minimally invasive technique. Lastly, I would like to draw your attention. You know, we have the Egyptian Sialendoscopy course and the first Pan-Arab course. It has been postponed to 4 to 6 October. Hopefully things will be better in the world and we would get that done. And followed with that, we have our big international meeting, Alex from 7 to 9 October. And we hope to see you all there. Thank you very much.
Thank you, Dr. Imad, for a very beautiful presentation. Your surgical pictures were amazing. For want of time, I am postponing all the discussion questions to be done at the end of the remaining 2 presentations. So I hope all the panelists agree. I now invite Dr. Aditya Murthy, who is a dear colleague of mine. We do most of the Sialendoscopies together. He is a facial-maxillary surgeon in Bangalore. He is now going to deliver a lecture on extraoral approaches to parotid duct pathologies. I welcome Aditya now.
Yeah, Dr. Magdi, can you unshare your screen?
Yeah.
Thank you. Please bear with me a little bit.
Any trouble?
Yes, one second. No.
Okay.
There we are.
By the time your presentation is ready, it's ready.
It's ready. Can you see?
Yeah.
All right. Full screen. Okay. View slideshow. Can you all see this?
Yes, we're watching.
One sec. Please bear with me. Sorry. Yeah, I had to change the computer in the midst of it. Is it visible? Thank you, Dr. Srinivas. This is a big deal to try and arrange this at short notice. I will straight away get on to the combined approach. What has happened is Dr. Magdi has spoken about what's the mini parotid approach, and hence I'll restrict myself to my not so mini surgery. I'm a bit ham-handed. I need bigger incisions. So the basic outline is the anatomical challenges, the challenges of the type of obstruction. Is it silolith? Is it a stricture? Is it a foreign body? If it's a silolith, does this approach allow us to retrieve it comfortably? If it's something else like a megaduct, and if it's a foreign body, what kind of foreign body it is, and how easy it is to retrieve it via this approach. So these approaches to the duct are going to depend on these ideas. So basically, for people who do not do this very often, I am preaching to the choir. I'm sorry if I'm preaching to the converted as well. The surface anatomy of the duct is like this. It is a familiar anatomy where the duct takes an almost 90-degree bend. It's almost never entirely 90 degrees. And it generally passes between the buccal and the zygomatic branches, with the buccal branch in a good percentage of the cases crossing the duct laterally. This is the so-called 90-degree bend. You can see this quite clearly on the MRI, this is a very schematic representation where it pierces the buccopharyngeal fascia, the buccinator, to come out opposite the upper second molar. So basically, obstructive sialedenitis could be because of a silolith, a stricture, mucus plugs and debris, a foreign body, or anatomical malformation. Here, the malformation is either a kink or a bottleneck, which is not a stricture. Very rarely, it could be a polypi. So when do we need to have this combined approach? If the stone is impacted and it's not going to move, the stone is in a secondary or a tertiary branch, your scope can get to it, you can see it, but there is no way you're going to get a basket around it. If it is posterior to a stricture or a bend which cannot be dilated enough for you to get the stone out even after basketing it, and you are able to visualize, unable to instrument. These are the common sense indications for a combined approach. So this combined approach could be, you could approach the duct either through a transoral approach. This is mostly limited to the duct after it passes the mesenteric bend, and yet you cannot entirely remove or deal with the obstruction intraluminally. A transcutaneous approach, this is a small area of about 2 to 3 centimeters where it lies on the mesentery itself after it exits the gland, or a smash flap, which is a superficial musculoaponeurotic fascia smash flap to approach proximal siloliths, a few of them which Dr. Magdi has already described. This video shows us a combined approach where I'm stuck with a impacted stone, but impacted only just behind the papilla. So what we need to do is we need to just go around the duct. I do not use the spatula anymore. I use a Colorado or a laser. And I do not use a circular incision. It is generally a crescent, and we dissect the duct out. Once you dissect the duct, you choose to place your incision wherever you want, ideally, or just behind the papilla, and retrieve the stone. I apologize for the haziness of the video. I assure you that my other videos will be better. Once you approach this, yes, it is ideal not to be tempted to pull out the stone here. You need to be very gentle to ensure that the duct is preserved, and you can stent it so that it doesn't fibrose and form a stricture at the end of the healing period. This is an example of one of the techniques for a transoral approach. I'll show you one more in a different context. And let's say that we have a stone in this situation. You can see on the left-hand side that this is well within the parotid parenchyma, in probably one of the branches, and not in the main duct. However, this was quite easily visible and very tempting because it was only 2.5 millimeters. But unfortunately, there was no way we were able to basket it. And after 20 minutes of faffing about, we decided that we had to open a smash flap. In these contexts, a little bit of experience has helped, not in operating, but in trying to tell the patient that they would need a smash, and we never assure them that anything is going to be an entire endoluminal approach, because we can't wake them up for a further consent. So like Dr. Magdi was describing, the procedure is simple. You transilluminate the duct, but my incision itself is slightly bigger than Dr. Magdi's. I dissect out the skin and subcutaneous tissue only, leaving some amount of fat and on the smash layer allowing me to raise a smash layer entirely separately. That gives me one layer to close on top of the parotid tissue. And I believe that this reduces both the chance of a silosele and Fraisse syndrome. We have had our first silosele, unfortunately, with these approaches last month. Till then, we had a very clear record, but that's never going to last, is it? Once the duct is identified, in this case, it was well impacted and the stone was stuck onto the basket. Once the duct is identified, you make a very small incision, allow the basket to move slightly back. In this case, it was impacted just behind the stricture. The incision allowed the stricture to open up and we could retrieve the stone. Once it is retrieved, I slightly differ from the other operators. I tend to repair the duct ideally over a stent. Only when it is quite impossible to get a stent into the position, I tend to close without having the stent in place. The advantage of this is that because the stent has several lateral ports, whatever small amount of collection that may happen around the stent tends to drain into the stent and hence into the oral cavity. And we do not tend to have either a salivary leak or a silosele. And this needs to stay in position only for about 5 to 7 days. There you are, the stent in position. Now to find the proximal end of the, see, the duct is not transected here. Unlike trauma, there has only been an incision on the duct and the continuity is established. So once the stent is in position, you identify the proximal end and very gently, yeah, there you go, very gently insert it into the proximal end. And I agree, I use 6-0-proline/60 ethylone to close it. I haven't found the necessity of using anything smaller. I do perform microvascular surgery, but I'm convinced that 6-0 will do the job. But then this, I think, is a personal preference. Transcutaneous approaches. This is something I was dogmatic about, wrongly dogmatic. We tend to become less dogmatic as we lose hair and put on weight. I had a significant issue putting in transcutaneous approaches, and I preferred to increase the size of the length of the incision. But as we realized that the sheer surgical trauma and morbidity would increase, it was becoming more and more sensible to have a small transcutaneous incision along the RSTL. So it would be a vertical curvilinear incision rather than a horizontal incision. The initial logic is tempting the operator to place a horizontal incision because that's the direction in which the nerve would be traveling. However, that is disingenuous because the incision is only skin and subcutaneous tissue. Your dissection can be horizontal, but if you leave a vertical incision, it leaves a horrible dimpled scar, however carefully you close. The buccal branch of the facial nerve is my concern. It's anywhere between 1 to 2 centimeters below the duct, but several times the zygomatic branch right after division crosses the buccal branch, crosses the parotid duct. This is a classic example of a curvilinear incision. As you can see, it's a very small transcutaneous incision. The stone is taken out. The same procedure happens where I insert a stent to go beyond the incision on the duct, and we close the duct over the stent, and the stent stays for about a week in this case. There are some contexts where we need to have significant transoral dissection up to, or if possible, beyond the mesenteric bend. The management of a megaduct has been a very, very big challenge. I have to say my results have been indifferent, and it is still a learning curve. Probably when I talk to all of you nice gentlemen later on, I'll probably learn a little more. But one of the most important requirements for this is a transcutaneous approach for a megaduct. So once we identify the papilla, I tend to ensure that the papilla is transfixed with a suture and big enough incision to start dissecting onto the wall of the megaduct. And as we see the megaduct, we sleeve the megaduct out by excising one lateral wall as far back as we can go. As you could have seen in the scan, it is quite impossible to go on to the second limb of the sausage there. But the idea is to get beyond the first stricture so that the pressure in the megaduct decreases, and over a period of months, the megaduct and the swelling comes down. It's vital to tell the patient that it's going to take that much time. As you can see, the duct here itself is small. There is a stent over which it has been repaired. You can also see that I'm partial to stents. That has been one of the criticisms here. But here, we use the biggest stent we have. This is about 10 French. The stent itself is about 3 centimeter outer diameter. 3 millimeters outer diameter. My apologies. You can see the buccal fat pad. Sometimes the buccal fat is wrapped around it, especially if the sleeving has been overdone. But in this case, it was quite all right. And there you go. This is very similar to, there you are. It's the same tap Sirish had opened in his presentation. And you can see the buccal fat pad coming out. I can see what is okay. The problem here is that they do very well in the first 6 weeks, and the symptoms come back after that. Parotid foreign body. This is an interesting case, which was a bit of a challenge for a combined approach. Linear metallic looking foreign body. It was well reported that it was metallic, and the incision we chose naturally was not the incision we marked. This is a verticalish incision, and once the foreign body was removed, naturally this barbed foreign body would never come out through the duct without tearing it. We did not bother to pull it out. There was a fair bit of calculus stuck to it. All the concrescence was held by the basket. We cut it open where we could move the basket and could feel some movement underneath, and we stented it and closed it over the stent. Occasionally, post maxillectomy, the 3 cases I've had to do this, where once maxillectomy is done, the patient's been radiated, or even if the patient's not radiated, the parotid duct or whatever left of the parotid is there tends to shrink into the cavity there. In this particular patient, the patient wasn't radiated, but he had a denture, and he ended up having a huge water brush going into the maxilla and coming out through the nose. So the idea was to stent the area, dissect the duct out, and reposition the duct about 2.5 centimeters towards the inferior. And with these approaches, I thank you for the opportunity you've given me, and hopefully I will have time to answer a couple of questions. Thank you.
Thanks, Aditya. Now we move on to the last lecture of the day. I would love to invite Dr. Anand, who has been patiently waiting for all our talks to get over and has actively participated in all the discussions. Sir, your interesting scenarios now.
Okay.
Adi, you have to
yes.
come.
Yes. How do I stop?
You're out. You're out.
Oh.
You unmute. You have to mute yourself.
Sorry.
Dr. Anand.
Yes. Is it okay?
No, sir, we are not yet seeing your presentation.
In my computer, it is on.
Did you share screen?
No, I don't think so. I think I just went into the
presentation.
Yes.
I just share screen, sir.
Anand, first minimize your PPT, then share screen.
Yeah, it has come, sir.
It has come?
Yeah. Now full screen.
Okay, this is the part 2. How's my voice? Voice is okay?
Yes, sir. Clear.
Okay, you have 8 to 10 minutes, right?
Yes, sir.
Okay, fine. So we have already covered all this, and fragmentation by lithotripsy, forceps, laser, etc. And here I'm going to talk about a little bit small techniques and tricks which will help all of us to do this particular method. So twin endoscopic approach, already it has been discussed well. We use this twin endoscopic approach for megastones, and we generally leave the posterior incision unsutured. And one point I want to mention is the posterior approaches intraoral are better done with nasal endoscope and not with microscope. With nasal endoscope, we have a much clearer vision and with no fogging and etc. That's one thing. And the lingual nerve, it has already been covered well. This is the instrument which I told you, the other end of the tongue blade, which we use to retract so that we can see the lingual nerve. Now, another one point I want to add is, before you identify and preserve lingual nerve, make sure the veins which are crossing your path, before they start bleeding, they have to be cauterized with bipolar under irrigation and divided. You don't leave the veins for them to create trouble later. Second thing is, there will be a few pieces of fat, which sometimes you can even get a few lobules of salivary gland coming here. And those lobules of salivary gland or lobules of fat have to be divided so that we get a clear view of the hilum area of the submandibular gland. These are the double approaches of submandibular gland. Again, all these are documented with nasal endoscopes, which give, I feel, a little better vision. So these are points already covered, and this is already covered. This is something which everybody does for a palpable floor of mouth stone. Make a sialendocotomy and remove. The only point I want to add is put a safety stitch behind, because this will prevent you from sliding the stone back. Okay, just put a safety stitch with some silk so that the duct is closed when you do this manipulations. So these are the advantages of twin approach. I told you, for better hemostasis, one point that was not covered is it has to be before bleeding itself, the veins have to be cauterized, and glands or gland substances or fats that come into your way have to be dissected off before we go in for it. Stent placement has already been covered well. I don't want to again spend time on it. These are the concepts of Neheli for recurrent parotitis. I think Binny has covered it admirably well, but he uses certain things like balloons and micro drills for strictures. And steroids, originally hydrocortisone only was recommended, but I find that using synthetic steroids like dexamethasone also, there is no problem. Injecting depot steroids only in the post-op period or in the measured area of a stricture, but not during surgery. These are the multiple stones that have been removed. Remember always, as Dr. Naulaki also told, if you uncover one stone, there may be several behind it, and it's better to do scopy. So even if you don't do Sialendoscopy and want to remove stones, you have to look behind them and make sure that you don't leave behind other stones. So this is for that mini incision. Here, Dr. Aditya Murthy told about the incision here. It's rather tricky and difficult, but not all patients will agree for a largest incision here and coming for a flap. In cases where the stone is somewhat palpable, that simple technique what I use is the same technique used for identification of the internal laryngeal nerve in your thyroid cartilage, where we use something called a needle walking technique, where we use a 26 1.5 inch needle and walk on this substance till the needle impacts on the stone. Once the needle impacts on the stone, cut round the needle and straight you can reach the stone. Okay, that is one way of identifying the stone when you want to do a mini approach like this. And as the other points have already been covered here. Okay, here one more thing. I think Dr. Magadi and as well as Murthy told about using the Sialendoscope for illuminating the stone site while we work on either mini parotid incision or an external incision like this. Now, to keep a Sialendoscope in situ while we do this work, I find it's a little difficult because when we are engrossed in doing this surgery, this Sialendoscope is not taken care and it may bend or break and so on and so forth. So what I believe in using is to use the illuminator that comes with the Indian balloon sinoplasty system. We have these illuminators which is flexible and sterile, but it's about 1 millimeter in dia and it can be kept into the duct to illuminate the site of the stone. First you identify the stone, measure the length and pass this illuminated guide wire till you reach the stone. These guide wires are flexible and they will not endanger a break or something. So it's easier to manage than Sialendoscope. So when you have more than one calculi, what to do? So Dr. Naulake had told about using the hand drill, but the hand drill also can be a little troublesome when it comes to a large stone like this here. So there what I did is I used one of these ear drills. Basically the 0.3 and 0.6 mm hand drills made by Stars have a hand piece which is acceptable to these autologic hand pieces which are used by majority of us. Only thing you please make the drill rotate only at around 200 to 400 RPM like how you use for stay piece foot plate. In that case, you can use the hand drill along with the regular mechanical drill and do this. For all these work, I believe in using the larger 1.6 mm Erlangen scope. The side effects, it hasn't been told by most of them. I think we should warn patients about all these side effects. And I think one of the prominent side effect is recurrence of stricture, and that is possible to overcome only by repeated dilatation. And instead of them coming for repeated Sialendoscopy, I believe in giving them these Venflons, 24 FG Venflons, with which they can irrigate through their stents and keep on dilating. And you can give them just saline or saline with amikacin, or sometimes I mix steroids with it. So this is one of the cases where the basket got locked up, and the basket doesn't usually break, but it gets locked up and it doesn't release. Means you can't take it out. And I think Naulake told it's better to cut it and remove. But what I do is I make an independent incision behind the papilla and then take out the basket. And once the basket is taken out, then the stone can be easily released and the basket also can be removed intact. So these points have already been covered. This is one thing which I think Dr. Magadi also told. There's a steep learning curve in this Sialendoscopy. In fact, the first 5 years of my Sialendoscopy, it was difficult. You see, especially pediatric age group patients, we had to go for external approaches because we are not successful in removing it. This is one point which has not been covered. the size of stone that can be removed in children are markedly smaller than when it compared to adult. For example, 4 mm is okay in an adult, but 4 mm is too big for a 12-year-old. So watch out on that pediatric side. The ducts are not as big as adult, not like otology where malleus and incus in pediatric and adult are all same size. Here ducts are quite small. So post-op flushing has already been told. The results, as I had told earlier, initially the Sialendoscopy group, we had reasonable success, quite a bit of failures, and that led to a sort of a feeling. They ask for Sialendoscopy, then they go for open surgery. The thing is, initially, quite a few cases had to go for open because our skills were limited. But now, with gathering of experience, our external opening rates have become less. But this has to be conveyed to the general surgeons or general practitioners, and then only we'll be able to get more references. I think I just wrote down a few points. The pediatric cases we have to watch out. Use of illuminated guide wire that comes in the sinuplasty system, not by Acclarent of USA, but this is an Indian company from Gujarat which makes it, reasonably priced, and they work well. I have no conflict of interest from this company. Intraoral approaches, be ready to remove some amount of fat, some amount of salivary tissue to gain access to duct as well as the lingual nerve. The walking technique of the needle, especially on the cheek, use a IM needle, walk on the soft tissue till you hit the stone, keep the needle there, cut on the sides of the needle till you reach the stone. Foreign bodies inside the duct, people have identified even fish bones inside the salivary duct, and I feel we should not make too big an opening. Especially Indians have a habit of nicely gargling the mouth very forcibly, and it is understandable that foreign bodies like areca nut or things like that can be driven down into these large slit ducts and become foreign body. So nature has given papilla and small openings. So I think we should also try to follow it and not make huge marsupialized ducts. One more thing is, when you put a stent into your submandibular duct, I think Dr. Navlake told that point clearly, that you have to put a stent when you open double approach into the hilum. There, many of my patients where I have done it, the tip of the stent, though it is soft, whenever they swallow, when they eat, it goes and impacts on the bend, S-bend around the mylohyoid, and they get a lot of pain. So it is better that we avoid straight stents, and in future, Murthy can develop and give us one of those little bent stents which we can use for submandibular gland, especially beyond 4 centimeters. If it is bent for about 1 or 2 centimeters, it will be good, because when they swallow, it won't impact on the duct. I think these are the points I want to emphasize. Thank you very much for giving me the time.
Sir, your concluding talk was filled with a lot of wisdom and experience. I think it was an apt concluding talk. All the questions which have been asked by audience on the web, whether they're watching Facebook or YouTube, you have very nicely been able to bring out all those points in your last talk. I think it hardly leaves us with any amount of questions which need to be discussed, but I leave the floor open so that if any one of our panelists want to add something at this point of time, other than saying thank you, they're welcome. Or rather, I will call out each of you. You can conclude and then thank. Dr. Aditya, start off.
Yeah, the point is, I think the illuminated guide wire, I had not heard of it. Naturally, I'm a max fac surgeon. I think it's an amazing tip and trick to pick up. It's going to change the way I practice, because I have always been petrified of breaking my scope when I do a combined approach transcutaneous. I just have to thank Dr. Anand for that tip he has given us. I do not know how many more people use it, but having done such operations, it's great. I think this is something we have to pick up.
Dr. Aditya, that is an equipment which people who do balloon sinuplasty use. So your other good friend, Dr. Sunil Dutt, should be able to help you.
I think Dr. Santosh Shivasamy, in Columbia, Asia.
Yes, sir.
He uses this same equipment.
Okay.
I think Santosh will be able to help you with this sourcing of the illuminated guide wire, because I got it from Bangalore only.
Oh, okay. Thank you very much, sir. Thank you.
Will the laser fiber give the same kind of illumination? A laser fiber?
Yes, it will. But you have to use the visible beam, aiming beam for your illumination, but it won't be so.
Right.
They use basically a ruby laser for illumination. It won't be very bright. The thing is, you want to use these techniques for illuminating where the stone is. You saw Dr. Emad's video. When they put the Sialendoscope, even if you keep the light very low, it's so bright, it doesn't show pinpoint. There's just a big pool of light within the center of which you have to assess with your clinical sense, you have to go. I think you have to use lesser light for guidance actually. And one more thing, if you see my presentations, some of my presentations show the green light in the theater. Okay.
Dr. Anand.
Yes.
I think your slide is going auto. It's causing.
No, I'm pressing it. See this slide. This is the regular theater. This is the green light. The same theater. This is with white light. This is with green light. When you use green light in OT, your Sialendoscopy video or nasal endoscope, whatever, everything becomes more clearer, and these illuminations within the duct are becoming more prominent. Okay, and these are not very expensive green lights. They are just green tubes. Okay. Some surgeons have made us all believe that they cost tens of lakhs of rupees, but I think a tube like this costs about 100 rupees, I think.
Thank you, sir.
Well, to circumnavigate this problem, what I do is I use a modular scope. So I identify, once I've identified, I fix the scope, but then I withdraw the optical element out.
Okay, I will act like the bad moderator now. Concluding statements.
Dr. Imad wants to say something.
No, I will be coming to him. Bini, concluding statements.
Okay. Yeah, very nice, Srinivas. A very good initiative also, and learned a lot. Can I ask a question to Varun? I was thinking we were talking about lasers and its damages. So is it possible we can use ice cold water irrigation or something to reduce the damage?
Okay, he will answer that question when I go to him.
Okay. So
next, okay, Dr. Sirish, concluding statements.
Yeah, I believe Sialendoscopy is a wonderful thing for the patient. For us, we have to go through a lot of training to understand it and the learning curve. But I think it's rewarding on both ends.
Yeah. Dr. Navlake, concluding statements.
Yeah, can you hear me?
Yes.
Okay. So what I would suggest to new surgeons, definitely join in for doing Sialendoscopy. Very good tool. Start with simple cases, have some trainer with you, get some training, and you should be one of us.
Okay. Dr. Varun.
Yes, sir.
You have a question to answer and then concluding statements.
Yes, Dr. Bini, thank you for asking that question. This was a question which was first put up about a year back in Geneva under Dr. Marshall. And there were quite a few people doing that. I myself have shifted to using cold water, but it's not made any difference at all. It still has to be, there have to be further studies. But just as a general level of precaution, yes, I have shifted to cold water while using the laser.
Okay.
And
any other comment?
So much for having me here. It's a wonderfully organized event, and I'm sure a lot of people will start soon.
Okay, Dr. Imad Magdi, your concluding statements.
Well, actually, I want to make a comment first about using the light. I think the proposed thing by Dr. Anand is a very nice idea. My only caution about that is that some actually people don't leave the scope in. They actually put a guide wire and mark the stone externally, and maybe use the ultrasound also intraoperatively, and then put the scope again. The thing that happens when you're doing that is when you're actually doing the external part, the guide wire tends to move. And I'm sure that is going to be the same thing that happens with the eliminated guide wire. So when it tends to move, you kind of lose the sense of where your actually stone is exactly. The ideal thing is keeping the scope inside all the time. The downside of that is that your scope could break. Well, let me tell you that I've been practicing Sialendoscopy for 10 years now, and I only have 2 scopes, 1.3 and 1.6 all in one. And I've managed to keep these 2 scopes live for these 10 years. People who know me know that I'm a very meticulous person, and the people working with me are extremely meticulous. So I actually dedicate an assistant to be taking care of this scope all the time, and I've never lost the scope. Yeah.
I just want to tell you one small trick to make the scopes live longer. At the end of your surgery, how do you wash the scopes?
Actually, I wash the scopes by myself, and I start by irrigating by saline. And
never irrigate with saline because it has salt.
I'll tell you what I do. I irrigate with saline, and then I brush them with the special brushes, and then use distilled water at the end to actually flush out any remaining of the saline.
I think that point about distilled water is very important. I think we are thankful that you told about this, because without that, all these small channels get clogged in no time.
Exactly.
You won't break the scope, but once the irrigation channel is blocked in a combined scope, the scope is a little difficult to use.
Yeah.
I think the point is very important.
Yeah, it is.
Thank you, sir.
And you have to have these brushes, these very fine brushes done by stores. They actually clean your scope and also clean your bougies. If you're using bougies, you have to clean them too. So again, I would like to have the link for the eliminated guide wire, because I want to try that. So if you can send that link and we can get some of these eliminated guide wires here in Egypt, that would be wonderful. My concluding remarks are that, believe me, even though today is Eid and I have to be with my family, I think you're my Sialendoscopy family. I enjoyed very much this discussion, even though it's not in person. Maybe we'll, hopefully soon, we'll have other discussions in person, maybe in Alexandria or in Egypt or in India, whatever. But hopefully things get better. And let me thank you. I've learned a lot, and look forward to more and more collaboration between us in the future, inshallah.
Thank you.
Thank you. Thank you. Thank you all. Before concluding, as the moderator, I have the onus of giving the vote of thanks. I thank all of you individually, Dr. Bini, Dr. Anand, Dr. Imad, Dr. Varun, Dr. Milind, Dr. Sirish, and Dr. Aditya for having given your time on a Sunday. And we have we have outlasted the time by an hour. We have exceeded the time by 1 hour actually. So
any number of attendance?
I think around 207 was what was told to me when initially we started. But I'm sure we have actually learned quite a lot from the interaction. So many points to take home. Dr. Bini's protocol for managing her bile adenitis patients was an eye-opener for us. Dr. Anand has given us so many practical inputs, which is like next to, I mean, it's difficult to replace. I mean, I suppose that's where experience counts. Dr. Imad too has brought in his share of experience, and I mean, as I have repeated multiple times, it's his festival day, but then he has been kind enough to spend time with this family. Dr. Varun's laser talk was amazing. Dr. Methylene Blue has so much of material in his computer. I think one day wouldn't be sufficient. But then you did a good job with your large submandibular duct stones. Shirish's talk was a repetition for me because I had listened to this in Dubai. But as usual, he carried along beautifully, and then it was an amazing way of showcasing how a modular scope and its various sheets could be used to dilate. And Aditya has been my companion. We could rather be brothers in arms. So, so he is always a nice person to have to talk to. He's very witty, and he does bring in a lot of sarcasm in his talk. Today it was devoid. So, so one thing that the audience who is listening to about Sialendoscopy, which you need to understand, is one scope is not sufficient. You will probably need to have an armamentarium which encompasses at least 2 or 3 scopes. They are expensive. They are fragile. Despite what Imad Magdi told that he has been using only 2 scopes for 10 years, that's an exception rather than the rule. So you will have to be prepared that you are spending quite a good amount of money in investing on this equipment. 2, you are seeing 8 of us who are here, and unanimously all of us have told it is a steep learning curve. This probably has been because Sialendoscopy was something which we all picked up as our tertiary subspecialty or a quaternary subspecialty after we have already got into practice. The younger generation, if they pick it up early, maybe their hand skills are far better than ours, and better teaching modules which are being established across the country and across the world will probably bring out better hands, and they probably will learn it earlier. Towards that end, Dr. Methylene Blue can be contacted. He runs a course 2 or 3 times a year. So towards that end, that's a great opportunity for the youngsters. I think with the innovations of the stent which Aditya and Prithvi have brought out, and with inputs from seniors like Dr. Anand, I'm sure we will be able to get quite a few of the consumables being to be made in India itself. Once the consumables are made in India, I think the cost will come down a lot. The consumable is the one which is actually killing the bill. So with these words, I would like to conclude thanking all of you and CIPLA for having facilitated the whole program. Thank you, CIPLA team, and thank you one and all.
Thank you.